So yes, so protocols. One, definitely start reviewing them. Definitely start getting at the very least, the adult protocols down cold. Okay. Um, Two, when you are reading scenarios, do not get sidetracked by things. So, in the scenario that you were given, that Scott gave, a 52-year-old male ingested an entire bottle of diltiazem after a fight with his ex-wife. Patient is drowsy and mumbling incoherently. Vital signs are heart rate of 48, sinus brady, BP 82/36, respiratory rate 24, oxygen saturation 91%, finger stick 414. What's the patient's problem and how would you treat them? So from what I understand, one, some of y'all were like super excited that you had not only cardizem but also a hyperglycemic. In these scenarios, don't get distracted. Patients get one problem. That's it. They don't get more than one option. You get one major complaint. Yeah. And this, I have gone on scene and told the patients like, I don't feel good and this hurts. I'm like, listen, you get one complaint. Pick one. What's the worst? So kind of go with that mindset when you're reading scenarios. Like, what's the worst thing that's going on right now? So this patient is clearly, he's incoherent. He's mumbling. Now, my problem with this scenario is you don't have a whole lot of information. For example, when did he take this whole bottle of medication? Was it witnessed? Is the empty pill bottle on scene, right? So these are some things, because like if he took this bottle of cardizem 5 minutes in the past, his blood pressure being 82 and sinus bradycardia and his AMS, personally, I would not think that would be secondary to his cardizem and hasn't had enough time to digest in his system yet. But if the scenario said 30 minutes prior, I'd be like, cardizem, 100%. The glucose is a distractor here. So don't let the distractor kind of entice you into going into down that path. So obviously, and in the protocols, correct me if I'm wrong for those of you who are looking at the unified protocols, because in current protocol, what is currently in existence, because I was like, we're going to plan ahead. We're going to give you guys the protocols going into effect in August, and then they didn't go into effect. You have to call to get calcium. Not 100% sure if that's
correct.
Okay.
Medical control option, calcium chloride.
So what is the very first thing in your bradycardia protocol that you can do?
Bradycardia?
Yep, bradycardia.
Atropine?
100% atropine. Now, and this is where I always got jammed up in medic school. Make sure you get straight in your head the difference between atropine and adenosine and amiodarone. Because it's like Alex Trebek, I will take cardiac medications that start with A for 200.
A.
Yeah, they all start with A. Like some sadist decided to name all of these medications. So as long as you get it straight in your head that adenosine is slow. So the first one is like you want to slow it down. Adenosine, slow. Atropine, you want to go fast, right? Amiodarone, cardiac arrest. Okay, if you can somehow separate those three medications in your head, you are going to be golden. That'll take you a long way. So if you also now look at your sinus bradycardia protocol, I do believe your second option after atropine is a bolus of normal saline.
Mm-hmm.
Correct? Now, if you look at your hyperglycemia protocol, the treatment is a bolus of normal saline. So you can treat two things at the same time, but you need to make sure that you're focusing on the blood pressure and the heart rate. So obviously this would be a phone call to medical control. Be like, hey, guy's overdosing on his cardiac medication. I would like calcium. And the doctor's probably going to go to you. Okay, yeah, give him that. And probably some dopamine too. Okay? Because as wonderful as the calcium is going to work, this kind of overdose is a 1-2 punch, where the calcium only lasts a short period of time, and you're going to have the dopamine come up and assist in the back end. I know that there are some people who put Narcan as the option, and I know exactly why, because some of you went, crap, I'm not as super familiar with my protocols as I really probably should be. I know I'm supposed to give a medication. The only medication I can think of right now is my BLS protocols for altered mental. I'm gonna sprinkle some Narcan. And if you said, I'm going to give him Narcan as a diagnostic to make sure that he did not overdose on multiple medications, you probably could have gotten away with it. But most of the people who put Narcan pretty much just made that little vein in the side of Scott's head go. So, but I understand where you're going from. You guys don't have a lot of foundation and a lot of context, and a lot of use of the protocols to really have a smooth sail through that scenario. But I think the majority of you did a really good job with it. And this is why now, as Joe said, we really need to start picking up the protocols. So we're going to review some of them tonight. I'm going to look at the ones that we have right now, because there's going to be, I don't know when you guys are supposed to start. I think November. You might get ALS rotations. December.
That's the foreseen time.
Medicat.
Yeah.
So we're going to go over the protocols that you have right now. When you guys actually do take the test, the REMAC test, it will most likely be with the unified protocols. We're going to see if that even happens, because the city was resisting the unified protocols in the first place. So they may or may not do it. But we'll talk about this. I also am going to go over some of the scenarios that I sent out via email for some of you guys to look at and kind of think about. And we'll look at those in conjunction with the protocols, so that maybe we can piece it all together, because that's pretty much what the problem is right now, is that you guys don't have a solid ALS foundation because we kind of piecemealed it all together. We're going to try to put a Band-Aid on that. Sound good?
No,
Cool.
that's the question.
Go ahead.
So my thing is with the scenarios, we should always try to deal with people with ALS, like look at ABC, and then before giving medication, obviously your patient is also meant to saturate it. That patient is SpO2 is very low. So all those things encompasses a lot first before we give medication. So that like why is like certain answers like that before we even give medications as far as anything else?
Because I think this was trying to draw out the ALS protocol side of things. I think that's why this is the issue. Oh, also,
Okay.
some people use nasal cannula. If I was grading this, I would have said not a problem, because if you put him on a nasal cannula of 4 and you brought his SpO2 all the way up to 99, then you've done what you're supposed to do. You did too much good critical thinking. I need you to roll it back to basics. Yeah. Everyone gets a non-rebreather. The Oprah version of oxygen. Remember that in scenarios. Everyone gets a non-rebreather. However, if you said, I'm going to put him on a nasal cannula because I'm anticipating that the patient may vomit due to the fact that he overdosed. See, it's also sometimes you have to produce a little bit of a rationale to reduce that full angry vein. And if you have a good rationale, no one can say no. You know what I mean? Had a job once, had a guy who was in an SVT at 220. Gave him the 6 of adenosine. It broke, but it broke long enough for me to actually see the isoelectric line, and the isoelectric line was a fib, so it was an AFib. So I called, and he's now retired. Bless you, if you never have to deal with this guy. Dr. Silverman. Dr. Silverman was a hard ass. He loved to restrict people. So he goes to me, I go, hey, listen, doc, I've got this gentleman. He's in a rapid AFib at a rate of 220. I gave him, he's gotten 6 of adenosine. I want cardizem. Why did you give him adenosine? That's not in protocol. Because when I first got him, his heart rate was too rapid for me to tell if it was an AFib, irregularly irregular, or if it was an SVT with aberrancy. And there was just silence. And I was like, I'm going to get restricted. And he's like, all right, fine. I was like, all right, cool. And this was like baby medic status. Like it was like within my first 6 months. So I was like, I don't know how I pulled this off. I didn't get restricted. And he gave us the cardizem. So if you can provide a rationale behind why you are doing what you're doing, you will have an easier time across the board. Okay, so I want you, when you're doing these scenarios and stuff like that, to really think, like, why is it that I'm doing this? Okay, and when we go over the protocol, we're going to be like, why is it that we're giving this medication? Because I think that's going to start to kind of link all of these concepts together, so you guys are going to excel, really. Because I think once you get on the ambulances and you start seeing all these things and seeing things play in motion, it's going to be a little easier. All right. Any other thoughts, questions, concerns, comments? Anyone need a refresher before we start? All right, cool. So I hope everyone's in a good mindset, because frankly, I think that this is kind of on the depressing side. All right, so we're going to start with, move you all up here in the corner. So, patients with special challenges. This is definitely more of the stuff that you're going to kind of see on the transport side, but every once in a while you will see some of this in the 911 side. So the biggest problem that we on both sides kind of deal with are the physical challenges that people are dealing with, right? So hearing, vision, and speech. For the most part, I think it's like there's a very small but very robust deaf community, and you call them deaf. They don't appreciate being called hearing impaired or mute. Mute is like a serious insult in the deaf community, because a lot of them have functional speech ability, but they don't necessarily know how to use it because they can't hear themselves speak, or they never learn because it takes a lot of speech therapy. So there's a couple different levels of hearing loss, where deafness is like profound hearing loss, can be totally deaf. Usually, like, they can maybe hear low levels of speech. Some ranges might be out, like, like as you get older, you can't hear like really high or really low pitches. Sort of like that, where their range of hearing is restricted. Most of the time, a lot of people who are deaf are born deaf. Some people choose to get the cochlear implants. Some of them do not. Some do choose to use hearing aids. Again, a lot of personal choice. A lot of patients who are deaf may or may not use American Sign Language. Again, that's a very personal choice for them and how they wish to communicate, because some of them will try to, maybe get speech therapy and speak. Some read lips, which is very challenging. But American Sign Language is like was it described as a trimensional language, right? So you have not only the language that's used with their hands, but it's also their facial expressions and their body language. So if you really need a good rabbit hole, you can there's a woman who did, I think, a TED talk on sign language, and she talks about the differences in like how like a single sign can be interpreted in different ways. It's a very interpretive language. It's not literal. It doesn't follow the same like subject verb setup that English does. It's a little more free form. If you need to have an American Sign Language interpreter, by law, hospitals have to have, at the very least, access to a video interpreter, which can be challenging also for some hearing impaired patients, because you're losing some of that context because it's two-dimensional. You may have to find another way to communicate with the patient. Other problems with hearing are conduction issues, where there is somehow an issue where the sound can't make it from the outer ear into the inner ear. It might be a ruptured eardrum. It might be earwax, right? It could be a number of different things. And then there's also sensorineural hearing loss, where the sound makes it through, but there's a problem with the nerve, or there's a problem with the way the sound is being transmitted to the brain. So it could be that there is a restriction in the ear canal, where the bones aren't fully produced, or what's the word I'm looking for? fully formed. That's the word I'm looking for. So lots of different reasons that people can have a difficult time, right? And then you can have mixed issues, right? Where it might be an internal, external, or a combination of the two. Central hearing loss is there's damage to the nervous system itself, right? So maybe you have a patient who has a stroke in the area of their brain that allows them to interpret sounds. Or perhaps it's audioneuropathy, where the nerve isn't working correctly. Again, we're not diagnosing anything. We are merely treating the patient or trying to communicate with the patient, because a lot of the times it's not that you're going to necessarily be coming to the scene of a patient going, I can't hear all of a sudden. It's more likely to be a deaf individual having either a medical or a trauma emergency. However, if you do happen to have a patient who has sudden hearing loss, you might have to do a little investigation. There's a good possibility that a sudden hearing loss in an otherwise healthy individual is trauma related, secondary to usually a Q-tip to the ear or an ear infection. Some hearing assisted devices that you might encounter. This is a cochlear implant on this baby right here. So this little piece that's attached to their head is actually connected with like a magnet, and it helps transmit sounds to the brain through the vibrations. Kind of wild, kind of cool, kind of just an interesting kind of setup. I don't know, whoever came up with that one was definitely creative. Hearing aids, right? Very, very common. Might not only be for patients who are deaf, but older patients also, as they start to get older and they have a hard time hearing, very commonly will use hearing aids, right? So we talked a little bit about this, right? So sign language, different configurations, bullshit, right? Turtle, a lot of really good ones that you can learn. Hello is a very easy one. So if you do happen to be introducing yourself to a patient who is hearing impaired or deaf, and happens to use sign language, there's a few things that you might be able to communicate, right? Hello is easy enough. When it comes to speech reading or lip reading, there's just like sign language, it's very interpretive on facial expressions and body language. There's only approximately 30% of lip reading that a person can actually interpret. Sometimes it also requires you to speak slower. I mean, for myself, I know I speak very quickly, so you might need someone to speak a little, if you're a fast talker, you might need to slow yourself down to a more normal pace. And obviously right now with COVID, it's a little difficult to read lips with everyone wearing a mask. So situationally, you might not be able to participate in some of these, whatchamacallits. Visual impairments. A number of different things can cause visual impairments, from brain surgery, brain tumors, cataracts, damage or to the eye or the optic nerve, various infections. Babies, when they're born, if they happen to get an infection from the vaginal flora in their eyes, they can have an issue. Vitamin A deficiency, when your mom told you, hey, eat your carrots, they're good for your eyes, she wasn't lying. Okay? Visually impaired patients, you don't want to like sneak up on them, right? You want to, like, I don't know, tell them what you're going to do. This is a really fantastic opportunity to kind of explain to the patient what's going on. Because we don't really do that as much as we think we do, right? So you're going to maybe talk to patients, say, listen, like, we're gonna get you on the stretcher, we're going to sit you down, we're going to get you comfortable, I'm going to look for a vein because I need to start an IV to give you a medication, right? So that little like running narrative sometimes helps them feel a lot more comfortable than all of a sudden you're poking them with a needle or taking their arm in a direction that they're not prepared for. This is just fun.
Boss-eyedness is something which affects 1% of Britons. It doesn't impair eyesight, and yet people with boss eye are routinely discriminated against. Just like any form of discrimination, it should be stopped. But we can only do so with your help. That's right. We're looking at you.
If you guys would like an older TV show to watch, it's called The IT Crowd. Quite delightful, dry British humor. Other than some visual impairments, sometimes speech impairments, right? There's a number of different reasons that a patient might be having a difficult time communicating their normal way. One of the biggest and most emergent ways or reasons that we will deal with on the 911 side is aphasia, which is related to a stroke, right? So if you have a patient who you're expecting to be able to have a normal conversation with, and they're all of a sudden like telling you like, yeah, pumpkin flower petunias, and you're like, I'm sorry, what's your name? Pumpkin flowers petunias. And you're like, oh yeah, no, that's something's not quite right. Or they're trying to talk and it's not coming out, right? All different types of speech impairments, if they're acute in nature, should be high suspicion for a stroke. Backing up to visual impairments really quick. Visual impairments, especially if it's in one eye, acute and kind of associated with chest pain or like a in between the shoulders pain, can be a sign of an aortic aneurysm. So keep that in mind, because there's one of those like random things that might pop up that you're like, that's strange. Like the patient's saying that all of a sudden she lost vision in one eye, nothing else seems to be wrong. She passes a stroke test pretty deftly. Have some suspicion that there's, a more serious problem in a distant part of the body. Back to speech real quick. Most of the time, patients who have a speech impairment, again, they know. They're either born with some sort of issue where they can't produce speech well, right? If a stutter, or just aren't able to maybe project, right? They have a very quiet voice. Also, sometimes it's secondary to like a head injury or a brain tumor. So just things to keep in mind. Might be just difficult to get information from the patient. And sometimes, especially patients who have a stutter, if they're in an emergent situation, that could make their stutter worse. So you really need to exhibit a little bit of patience for them so that they can help explain what's going on. We're not going to go heavy into these things because, again, we aren't going to be diagnosing these things. But you do need to understand that sometimes the speech impairments are secondary to damage to the nerve pathways. Okay, it could be because of damage to the throat or the larynx, the epiglottis, mouth, lips, tongue, right? Or it could be a psychological issue, right? So some sort of emotional disturbances that could create issues when it comes to expressing themselves. The bigger issue when it comes to voice production disorders are acute onset ones. Okay, so if you have a patient who's complaining of an acute onset of hoarseness, I'm going to stop the share for a sec. You have a patient who's complaining of an acute onset of hoarseness or difficulty like speaking. What are some of the things that you would expect or you would want to check for?
Obstruction, airway obstruction.
Airway obstruction, good. What else?
Any swelling or redness in the throat.
Okay, which could be secondary to what?
Allergies.
Allergies.
Anaphylaxis, right? That's pretty emergent. What else is another one?
What about environmental?
What kind of environmental?
Like, I don't know, like exposure, something chemically?
Good. Toxic exposures. How about just an infection, right? Maybe they have, some sort of strep throat or something going on, right? Especially with the younger kids, they could have that issue. So there's a number of different things that can cause that. Brianna, yes.
What about radiation treatment?
Yes. Oh, that's a good one. That's a very good one. So radiation treatment can cause a lot of inflammation and swelling, and neck and like throat cancers are very challenging to treat. So these patients will probably also have like a trach or some other we're going to talk about those in a little bit, some other accessories that you might also kind of experience when you're dealing with them. So there's a number of different things, right, when it comes to speech impairments. We talked about fluency disorders, right? Patients who also happen to have a stutter. There was also, hold on, going back to vocal cords, right? So disorders that affect the closure of the vocal cords beyond anaphylaxis. There's also, I read an article, it was pretty interesting. They were talking about preteen and teenage girls who would experience wheezing, like kind of wheezing sounds during difficult excursions, or so like if they were out exertion. So if they were out and doing like a hard workout or running or something like that, they would develop this like wheezing, and they were being diagnosed with exercise-induced asthma, but they had perfectly healthy lungs. It was actually a laryngeal spasm that was causing it. So something like that, right? So just like, and these are like little things that you're going to start seeing as you start working more and you start experiencing more like a variety of calls, especially on the ALS side, because BLS you kind of get the same stuff with like a little peppered in curiosities here and there. But as you start working ALS, you're going to see some stuff that just doesn't fit the mold, and it's going to be the stuff that you're going to remember. And when you see it again, you're going to be like, I know exactly how to treat this. Okay, so make sure those like interesting calls, you kind of talk them over with like your partner, review them in your head, be like, okay, what happened, what was it, and how can we do it better? It's a huge part of reflection that's going to be helpful as you guys start to develop more of like a repertoire of different calls that you know how to handle. Obesity, a huge problem here in the United States. But obesity is considered 30% above ideal body weight. Again, it also depends on a patient's body composition. Let's call it body composition, because you're going to have that dude, that meathead juicer, who, if you put him on a scale and his 5'5" little brain, you know, his little 5'5" body should be 150 pounds, he's, you know, 190 because he has traps the size of watermelons. Like, you have to really kind of take the BMI kind of, or the body weight mark into consideration as what else is going on with the patient. However, obesity is still a massive problem in the United States. Obesity causes inflammation. Inflammation causes all sorts of other serious concerns like heart disease and stroke and diabetes and cancer and just, you know, oodles of fun. Most of the time, your run-of-the-mill obesity is that the caloric intake exceeds the caloric output, right? So people who have a 4,000 calorie diet who don't exercise, right? That's not going to end with, you know, Kate Moss. That's going to end up with, you know, someone who's on the larger side where it's like my 300-pound life. Patients who have a low basal metabolic rate, right? Particularly patients who have hypothyroid or poorly maintained hypothyroid. And again, not necessarily just because the patient is non-compliant with their medication might not be well balanced for them. Depends on their, sometimes you get endocrinologists who don't necessarily follow up thoroughly. And they just tell the patient, you're fine, you're good, just take this pill and you'll be good, right? And then they don't necessarily, it's not necessarily good for them. It fixes it a little bit, but not 100%. And then you have the genetic disposition for obesity, okay? Back in the day, in human evolution, the body went through this cycle, right? So summer, you would gain weight because, or you kind of be on the thinner side because food was adequate. And in the autumn, when the food started to kind of become a little more scarce, right, because it's getting colder, your body would start to hold on to calories so that you would make it through the winter. Because if you were starving through the winter, you weren't going to make it to spring. However, we now live in a land of abundance. So we still go through that cyclical kind of hormone cycle, but we don't change our caloric intake. So we're eating at the same level each year, and then like everyone's kind of like, I feel a little pudgy during the winter. Yeah, because your body's like, it's cold. Let's hold on to all of these calories in case the famine sets in, right? Especially those who have Irish heritage were like, the potatoes, but where are the potatoes? Right? It was a bad time. The French peasants, if I'm sure someone has seen this meme where it's like, I try to lose weight, but my genetics remember that we were French peasants once, and like, ye lass, no problem, we'll put that weight right on your hips. So, this is just human evolution, and we've done such a fantastic job of providing for ourselves as like a people that it's getting a lot easier to become obese than to stay, in that kind of natural hunter-gatherer, very lean kind of format. Back to the potatoes. Anywho. But yeah, bariatrics. Huge problem here for us who like to keep our backs in one piece. It might require a number of people, right? And if you work for the privates, you're never going to get the right number of people to help you lift patients. The good news is that almost every single, it was actually a national mandate, moving people to the power load stretchers because they're like, those EMS people certainly are costing us a lot of money in those like back problems, knee problems. I wonder why. If you happen to be working in the city 911 system, they have two different things. One, they have this FDNY truck that you see here that has the lift, and then they have the bariatric bus. It's a larger ambulance. There's one of them in, I believe, every borough, and the most likely time that you are going to be requesting this vehicle is when you are in the Far Rockaways. There are a lot of nursing homes in the Far Rockaways, and there are patients who are probably about twice the size of this gentleman here on the bottom left, who live in these facilities.
Yes, I can attest.
Yes, they're a number of large, and even the firefighters like, nah, no. So they're going to exceed the maximum for the stretcher, so they actually come with this larger vehicle. So you might be on scene for quite the extended time while you're waiting for the appropriate resources. Back to BLS, right? We're going to kick it all the way back to BSI scene safety. Do I need additional resources? Yes, you need the Fidney bus. Reminders that most bariatric patients live at least 2 floors up. And if you're really having a horrible day, they will take you out your house in a net. Terrible. They actually had, like, backstory to this, they actually had to cut the whole window out to get this woman out of her home because she didn't fit through the doorway. Bariatric surgery. There's a number of different bariatric surgeries that a patient could have that you may have to deal with in terms of a complication for the most part. Most of the time, the things that you're going to kind of be encountering are patients who've had the surgery and are now either dealing with a post-op infection or some other post-op complication. Perhaps the sutures didn't, maybe they burst a suture because now they don't realize that they can only eat about the size of a grape, and they try to eat their normal size or meal, or there's some sort of leakage of gastric contents, or there's a number of different things. Okay, so they'll go in, zigzag your innards a little bit, and pretty much just create a brand new setup so that you are not absorbing as many calories or able to eat as many calories. That's why we drink our calories. Some of the complications, pain, vomiting, right? Electrolyte disturbances is a big one, okay? They often will tell patients when they are discharged that they might experience a number of these things. They also often will supplement it or supplement their new diet with like a multivitamin or something to that effect so that they do not have more significant electrolyte disturbances. Obstructions, okay? All fun things that can happen. All right. back onto the happy stories. Paraplegia and quadriplegia, okay? So paraplegia is weakness and paralysis of both legs, and sometimes parts of the trunk, where quadriplegia is all four extremities. I have seen some textbooks call paraplegia or call quadriplegia. Let me rephrase this. Quadriplegic patients who have the ability to move their arms or their hands. Some literature calls those patients also paraplegics. So it's a wise idea to kind of find out what a patient's level of mobility is in all of their extremities, and if it's different from normal, okay? Because if it's a relatively new paralysis that the patient's dealing with, it could progress, it could change, it could improve. So just things that you need to kind of take into consideration. For the most part, when you're talking about paralysis, the number one thing that comes to mind, obviously, is brain and or spinal cord damage. Multiple sclerosis, stroke, ALS, muscular dystrophy, lupus, all of these things can also cause various types of paralysis. But it's often very much associated with the loss of bowel and bladder control. If it's a very high level spinal cord issue, it could be breathing issues, because it might not just be an injury, right? So patients who have multiple sclerosis, maybe they're having a flare up very high in their spinal cord. Some patients like Guillain-Barré, right? Guillain-Barré patients have an infection and then they end up with ascending paralysis. So if all of a sudden you have a patient who's like, yes, I've been dealing with Guillain-Barré, and that paralysis continues to rise, they could have difficult time breathing, loss of the bowel, bladder control, etc. One of the bigger complications that you may encounter is what's called autonomic dysreflexia. Most of the time, it's patients who have a spinal cord injury at T6 or higher. Okay, T6 is nipples. Okay, nipple line. So what happens is the patient will have some sort of irritation below the level. Hold on a second. Will have some sort of irritation below the level of the spinal cord injury. It could be like a little plastic thing from the clothes, right? Little tag. It could be that they have a full bladder. It could be that their sock is like wound around their toe in a weird way, right? But something that if you were normally abled, you would be like, that's irritating, right? I gotta scratch, I gotta move it, right? But they are unable to A, feel it, B, respond to it. So their body starts to create this sympathetic response. So as it starts to create a sympathetic response, everything above the injury starts to experience a sympathetic response, right? So the tachycardia, the diversion of blood to the core, the fight or flight response, essentially, right? But everything below the level of the injury can't respond, right? Because you've lost connection with it. So you have this kind of this shift in blood and this massive shift in volume. So the patient will usually present as hypovolemic, okay? So let me put the picture back up so you guys can visualize it a little bit better, right? So as it's, they'll have an elevated BP above, right? Because now their heart rate should be going up, right? But below it, they're having vasoconstriction. They'll start to sweat above the injury. Below the injury, it won't, no sweating, right? So their body is doing two totally different things because it's lost control with half the body. Also very common with patients who are suffering from paralysis, UTIs, okay? Depending on how well the patient is being cared for, pressure injuries, right, DVTs. If the patient is kind of on their own, they might have some injuries, like kind of like the same thing as like diabetics, right? When they have that diabetic toe where they stub it on something and then all of a sudden it's like falling off 2 weeks later because they never realized it was injured. So again, if this patient is relatively able to take good care of themselves and they are doing that, then some of these issues will be kind of minimized. But as the patient starts to lose that ability to take care of themselves, a lot of these issues become more of a concern. All right, emotional mental health. Number one thing that you're probably going to see is anxiety disorders. Anxiety is associated with almost every single psychiatric disorder. Okay, so it could be that it's associated with depression. It could be plain old run-of-the-mill anxiety, but it could be that they're also having an MI, right? So you need to kind of make sure that you approach the patient in such a way that you're not kind of going, oh, it's just an anxiety attack, okay? Because we see it enough where you're like, oh, just an anxiety attack, but don't let yourself get caught up in that mentality. Always make sure that you do right by the patient. Mental illness, we talked a lot about this in the psychiatric behavioral emergencies section of the curriculum. So again, most forms of mental illness can be caused by either biological issues, psychosocial issues, or sociocultural issues, right? Where perhaps the patient experienced some level of trauma in their life, they were abused, neglected, or they have just very poor relationships with other people, where it maybe borderlines on abuse and neglect, or they're unable to kind of fit into the quote-unquote social mold. Most, as you see right here, most patients who have anxiety disorders, PTSD is considered an anxiety disorder. Some of the more rare ones are personality disorders. I know they like to use that for like TV and shows, right? Like the split personality, very, very rare. Other parts are there. But most of the time, if a patient has one mental health issue, they will have other mental health issues, okay? And it's all about how well the patient is managed or is able to manage their symptoms. There's some people who have a hard time taking the medications because it makes them feel so crappy, okay? Just keep that in mind, okay? Developmental disabilities. Once upon a time in the United States, patients with developmental disabilities were put into mental institutions, just like kind of everybody else, because they're like, we don't know what to do with it. Put it over there, we'll just deal with it later. There was a move in, I want to say the 60s or 70s, to move patients with developmental disabilities more into a community setting. So this brought to you situations like Rainbow Commons. I don't know if anyone has ever had the opportunity to go to Rainbow Commons. If you happen to ever work for Melville, they not only have Rainbow Commons, but Melville Estates. Okay, these are two community-based developmental disability neighborhoods, I guess. So there's like a number of different houses, and each house has maybe like 10 to 15 residents, and they have people who are in there and care for them. So you will be dealing with patients on a real, like a wide scale of developmental disabilities. So like for the most part, they're more severe because patients with like more minor developmental disabilities, usually their family will kind of take care of them because it's not totally overwhelming for them. But you have patients with the MR, cerebral palsy, just regular kind of developmental disabilities where they never cognitively progressed, okay? But they also usually have other issues as well, right? So maybe some really cognitively depressed Down syndrome patients. The fun part was probably about 7 years ago or so. This was a state-run facility, and the state decided, hey, we're not doing this anymore. So they sold the care portion of it to a private company. So the private company comes in and they're like, fantastic, we're just going to take over and we're going to do things our way, which really just never ends well. So they came in and they're like, oh, okay, all these patients who are on one-to-one, they don't need to be on one-to-one anymore. They are not exhibiting any issues. So within the first, I want to say, month of the private people taking over, we had a number of very severe calls there. We had one patient who was supposed to be NPO, because, or I think it was chopped foods, like, small foods, because he had a difficult time swallowing. They handed him a sandwich. He choked and went into cardiac arrest, which is where one of my fun lines comes from, where carbs kill, because trying to get bread out of an airway is very challenging, because once that saliva hits it, it starts to break up. So it's very hard to McGill's a bread out of an airway. Deli meat's the way to go. Literally. Another patient who had pica. If you don't know what pica, you're going to find out. What pica is, you're going to find out. Older woman.
Pica eating.
Pica. Yep, pica eating. Okay, good. Pica is when you eat non-food items. So, this private company in their, wisdom, but we've been here for like a week. She hasn't put anything in her mouth that she's not supposed to. Left her alone. She ate the majority of the cotton lining of her adult Pampers and was thrilled about it. She had a smile on her face. She was just so happy. She was just sitting there like munching on this cotton. I was like, oh Lord. And they're like, we think she's choking. And I'm like, that's chewing, but thank you. You can leave now. So yeah, patients with developmental disabilities, right? Very unique challenges that these patients have. Not a bad thing if they're cared for appropriately. Once that supervision is lacking is when they start to get really kind of injured. Patients who have Down syndrome, trisomy 23, 23, 21, 23. It's in here. Their cervical spine, right? They're at a very high risk of having cervical spine injuries because their head is a little larger, proportionally larger, and they don't have the same musculature that we do. So if you have a patient who has had Down syndrome who maybe had what looks like a minor injury from a fall, it could be much more serious. Just, these are some things that you kind of need to take into consideration. I think we're going to blow through this real quick. Yep, blowing through. Oh, trisomy 21. There we go. And there's always patients too who have a really hard time with major aspects of their development, right? So they might have no language, no speech. They might not be able to even sit up or have any meaningful motions, right? These patients need a lot of care. Autism, right? There's this whole spectrum of patients who have autism, some who are very, very high functioning, which is again a term that a lot of patients with autism don't appreciate. And then there are those who again require a significant amount of care. We talked about this. Trisomy 21 is Down syndrome. Depending, again, another spectrum, because not two people are always the same. Significant things that you want to keep in mind. One, patients who have Down syndrome tend to have a very large tongue, okay? But in combination with their very large tongue, they have a very small face, okay? So high risk of airway problems or airway occlusion. Two, a lot of patients with Down syndrome are also born with a heart defect, okay? For the most part, here in America, that's not a huge problem anymore because we kind of just fix it and call it a day. And we talked about cervical spine issues, okay? That could make trauma, patients with Down syndrome involved in trauma, a lot more severe than you would think they would be. A lot of patients who have Down syndrome can have a perfectly normal life, but they are at risk for early onset dementia. They are also at risk for obesity, which with obesity comes all of the other fun, such as high blood pressure and diabetes, sleep apnea, etc. So don't be, I guess, confused that this patient who looks like they're really otherwise healthy has a lot of other concerns. Intellectual disabilities is a variety of concerns. It kind of falls into right next to developmental delays, right? So they might have just the inability to learn. It could be due to fetal alcohol syndrome or birth defects of the brain.
Sorry, hang on a second.
Eh.
Give me 1 second.
We back? We back. Significant malnutrition. Okay, there's some children who are adopted from third world countries. Depending on what their situation was prior to being adopted, they might have had some significant malnutrition issues, right? Or lead poisoning. Lead poisoning can cause significant intellectual disabilities too, right? Child is otherwise perfectly normal up until they start consuming lead chips, and now they have a significant problem. They're not able to learn appropriately. They're kind of capped. It's almost always originates before the age of 18. Again, we're not diagnosing it. We're just recognizing it as a potential challenge to patient care. Cancer. We're not going to go into this crazy. But do kind of realize the most important thing you're going to kind of take away from this is that metastatic cancer increases a patient's risk for pulmonary embolisms. Okay, so a patient could really have no other signs or symptoms or risk factors other than having cancer, and they might not have known. Okay, this is one of the worst things too. They might not know the cancer is metastasized. Okay, is very frequently one of the worst things that you kind of end up realizing is that you'll go and you'll pick up a patient. The patient's like, yeah, I was just diagnosed with cancer like a few months ago and I'm getting treatment, this, that, the other. You're like, okay. And then something just doesn't seem right and they're complaining of like abdominal pain or like pain that's not where the cancer was or difficulty breathing or like confusion. And you're like, oh no, it's metastasized, right? Let someone who gets paid way more break that news, okay? But it should be something that you kind of bring up to like the triage nurse, like, hey, patient has cancer, there's a risk it's metastasized. Especially cancer patients who all of a sudden have a brand new onset of seizures. It's either secondary to chemo or secondary to metastasis, okay? It's like one or the other. So just keep that in the back of your mind. As I said, this was going to be a super cheery lecture. Chemotherapy radiation causes all sorts of issues. Other issues it can cause as hypocalcemia, okay? So you might have a patient who has some cardiac dysrhythmias secondary to the hypocalcemia because chemotherapy leaches the calcium out of the blood and out of the bones. So if you have somebody who's got some funkiness going on and they've just had chemotherapy recently, it might be that. Cerebral palsy is usually due to some sort of issue during fetal development. The patient is going to be afflicted with potential cognitive issues as well as movement problems. Most of the time, their movement is very stereotypical, I guess, so they kind of have like the contractures and they have like that spasticity, right, where they have a hard time maybe relaxing their muscles and moving through a full range of motion, okay? These patients will potentially require very careful packaging and some gentle kid gloves because, you know, that's tough. It's tough to be kind of stuck in a position, an uncomfortable position for your entire life. Cystic fibrosis. Hours of fun when your lungs are literally trying to kill you. So cystic fibrosis is a metabolic disease where your body doesn't break certain I think it's proteins down appropriately, and what it does is it starts to not only accumulate in the lungs, but it starts to back up mucus production in the pancreas, the liver, and the intestines. Okay. Oh, sorry, sodium. It is protein. It's a protein issue with the transport protein for chloride and sodium. So as the sodium and chloride is unable to move appropriately through the cell membrane, it causes a thick mucus. for the most part, these patients you'll see with the characteristic lung issues, but as I said, it will also cause other mucus production in the pancreas and liver, so the patient might have pancreatitis or develop digestive issues because of the intestine problem. For the most part, these patients will need a double lung transplant at some point. Usually they can, with therapies such as they have this percussive vest that they use to kind of help break up the mucus and get it up and out. A lot of steroids and stuff like that. For the most part, these kids can usually make it to their late teens, early 20s before they 100% need a double lung transplant. And that's the only thing that they can do to survive. They are very frequently diagnosed with pneumonia because, again, think of it, that thick mucus is like a delightful petri dish for bacteria. So it reproduces really easily and they get pneumonia a lot. Let's see, what else? Talked about this. Persistent cough. That's the percussive vest I was talking about. Ooh. Head injuries, something I'm really good at talking about. Patients who have had a previous head injury or TBI can display with a number of different issues. They could look completely, totally normal, or they can have a hard time with a number of different things. Sometimes balance coordination is a problem, and it really depends on, one, the severity of the injury, and two, the location of the injury. Cognitive issues, right? So a patient might have a hard time finding the right word, communicating, remembering things. Personally, I had when I had a TBI, it was my frontal lobe and my temporal lobe. I find that I have a hard time finding words very frequently. I do a lot of this. What's the word? And I lost my sense of smell. So, like, again, something that you never know or never see, but that part of the brain that the olfactory nerve actually runs into is gone. Like, it's just dead. Also right over here, this little part, dead. Just never came back. Didn't know that one until like last year. I just thought it was like, well, it just didn't grow back. Because it's like, the neurologist is like, oh, that nerve will grow back because your olfactory nerve has the ability to regrow itself. The brain, however, not so much. Different parts of the lobes might have different issues. Again, you are not diagnosing anything. If you happen to have a patient who has had a head injury right in front of you, this might give you a little bit of a, a map of what lobe was affected, but I think you can also kind of make that connection due to the part of the head that's actually physically injured in front of you. The occipital lobe is vision, right? Remember, if you've ever smacked yourself in the back of the head, you get the stars in front of your eyes. It's because you're actually just jarring the optic nerve. Fun story about the temporal lobe. There is a woman who had temporal lobe seizures, and they actually removed part of the temporal lobe in order to help her live a normal life because the seizures were so frequent that she just couldn't function. And she became a really good ultra runner because she had no concept of time anymore. So she would be running and running and running and be like, oh, it was like 5 minutes, right? And they're like, yeah, that was 5 hours. So your brain, wild place. If you happen to have a patient who has had a brainstem injury, they are probably going to be a little less like functional than the rest of people. Again, depends on the severity of it as well as how much is affected or how it was affected. If it was in a diffuse injury versus a direct traumatic injury. Cerebellum, right? A lot of language, primal issues. Culturally diverse patients, right? So, and I only know this specific number because I went to orientation today. There are 138 different languages spoken in Queens. It is the most diverse borough in the world. That being said, you may encounter a patient who is somewhat unfamiliar. They speak a language you don't know. They maybe have cultural practices that you are unfamiliar with. But this is sort of that time when you kind of learn a little bit and try to be respectful to a certain extent because you're there to really kind of help. Let's just talk real quick. The least diverse area is Breezy Point. Hilarity. But yeah, South Jamaica, super diverse. So if you ever want to come down to Jamaica to ride on the ambulance, you're going to see a lot of different things. This is also part of the reason that getting a good interpreter, if you don't speak the language, is important, because you have different dialects that can really affect patient care. Okay, I was working in actually it was Lutheran, and we went to this basement apartment for this Asian woman who was having a difficult time breathing, and we're trying to communicate with her, and she does not speak the language. I even had like an Asian partner. I think he spoke Mandarin. So he's trying to speak to her, and she's responding to him in like a language he doesn't understand. So he's speaking to her landlord who had called 911 for her. He speaks Cantonese. We're like, what the hell does she speak? We're like running through the different language. We tried Japanese, we tried Korean, we were running out of languages. We get to the hospital and she spoke Hmong.
That's like a dead language.
Yup, not so dead. We found her in a basement apartment in Lutheran, or the Lutheran watershed area. She spoke Hmong. And I was like, that's absolutely, we couldn't find, there was no one in the hospital. They had to call Language Line, and Language Line had to like rustle someone up out of bed and be like, hey, you speak this, right? And they're like, oh yeah. No way of communicating with this poor woman. So you should absolutely do your best to try to communicate with your patients. It is highly advised that you use Language Line because they are qualified medical interpreters, okay? So they are not going to sugarcoat things like a family interpreter might, okay? Just keep those things in mind. And yeah, there's definitely going to be times when you need to use a family interpreter because there's no one else around. But if you can, do what you can. What else? Moving on. This is the most important thing that you can kind of take away from cultural diversity is you don't have to agree with another person's culture or the whole group of their culture, but you need to not be an asshole about it. Okay? Like I think that pretty much like respect the patient's wishes, but also try to explain to them that you're there to help them, okay? Because again, there's a lot of different religions, there's a lot of different cultures, a lot of different beliefs in this world, and honestly, like difference, like that variety makes us more functional as a human race. So like let them have their thing. And this is also going back to the whole family interpreter issue. You might have grandma who's sick, who is very devout to whatever her beliefs are, but granddaughter is the one who is interpreting, who doesn't agree. She wants grandma to go to the hospital and be okay, and grandma's like, I just want to die at home, okay? So this is sometimes some of the complications you might encounter when it comes to using a family interpreter. Financial challenges. This number is probably significantly higher now, thanks to COVID and the fact that here in the United States, for the most part, health benefits are directly tied to employment. 2016, 28 million Americans estimated to have no health insurance. And then we introduced the Affordable Care Act and around that time. And unfortunately, the Affordable Care Act was not as affordable as it should have been. And that was through no fault of anyone other than the insurance companies, because when you privatize something as essential as somebody's health, there are no rules. The one good thing that was kind of brought out of the Affordable Care Act was the pre-existing conditions. Because how can you possibly go and try to deny a child health insurance when they were born with a heart defect? Like, how horrible as a human being can you be? A lot of patients, a lot of people in the United States have medical conditions. A lot of people have more than one medical condition. These are chronic conditions that need constant care. And this is an argument that a lot of people have where they're like, I take my medicine, it's fixed, I don't need to take it anymore. Like, no, you still need to manage it. And without management, like long-term management of chronic conditions, more acute issues can occur, okay? And this is a part of the issue. Also part of the issue with financial challenges is people's reluctance to go to the hospital even in the event of an emergency because they do not believe that they can afford it. Again, America. Because why would we make sure that you can live? Why would we want to let you be able to choose, why wouldn't we force you to choose between your health and paying the rent? The poverty levels in this country are also astronomical. I believe it's something like at least 30% of the United States lives in poverty, and a large majority of that are senior citizens. That's huge, right? You have people who fully believed when they were younger that they didn't have to do anything. They work, they'll get Social Security when they're older, and they'll be A-okay. And they didn't account for inflation or the out of control inflation that we have in this country. And they're living on a very fixed income. So you have older individuals who are living in homes with no heat or are eating peanut butter and jelly or cat food because they cannot afford actual food because of their fixed income. So you might come to this scene where you have an elderly person who's really, really sick because they can't afford their medication or they chose to take their medication over their food. Okay, so now they're having other issues. And poverty is a massive problem, massive. Not only does it have a problem with childhood development, right? Children from lower socioeconomic areas have lower nutrition rates, higher malnutrition rates, which means that they have a harder time creating the appropriate neural connections so that they can, actually get a good education and learn appropriately. And then lower socioeconomic locations also have worse schools because, let's talk about this real quick. In 2010, before that, the 80s, we did the whole No Child Left Behind thing, and we punished poor performing schools by taking away funding. Without the thought of maybe the fact that the schools were poorly performing because they didn't have the resources to take care of the needs of their students. Logic. Anyway, thank you for coming to my TED Talk. We're going to move on. Homelessness, okay? Another huge, massive issue in the United States. Very commonly associated with poorly managed psychiatric issues. But there are plenty of people who decide that I like being a vagabond. I'm going to go live in the streets. Sounds fun. It's freeing, right? The problem with living like that is it's tough on the body, and it can lead to a number of health problems, especially because of, limited healthcare access. Because the first few times that you go to the emergency room as a undomiciled individual, you might actually get, some pretty genuinely good health care. But then once you become a chronic user and abuser of the system, you kind of get pushed onto a corner, handed a sandwich, and then, discharged. So you go from having like really good care to not so good care. Hygiene is a problem, especially dental hygiene. If you don't have like a good clean mouth, it's going to screw up the whole rest of your body. There's a lot of literature on the topic. It's pretty crazy, especially your heart. If you have poor dental hygiene, your heart's just in for a beating. Boop, boop, boop. High system utilizers. We all know high system utilizers. Those, frequent flyers. It could be patients who are homeless. It could be older adults who are either trying really hard to stay in their homes, or those who are afraid. There was one lady that we took on the regular, and she would call every night around dinner time because she was afraid that when she went to bed, she was going to die in her sleep. So she called every single night and demanded to be transported because she just didn't want to sleep home alone. Like, these are some patients who could really benefit from either a social network or social workers. Some of the factors that are kind of associated with high system use. It also depends on the location that you're in. Again, patients who have a hard time managing their own healthcare, or don't have access to like a primary healthcare area. Patients who are high system utilizers who are not in like that like chronic kind of male homeless behavioral illness kind of category are usually congestive heart failure patients. Okay, one salty meal and they can flood themselves by accident. Okay, and those are also some of the patients that we put systems together like community paramedicine for to kind of keep them out of the hospital. Oh, good. We're done with that fun. All right, how we doing?
No,
Great. Hey, Nicole, I wanted to add one
Sure.
thing to your discussion about financial resources of older people. What a lot of us don't recognize is that people who age and have resources may not then have resources later, because what happens is Medicaid gets involved and they will reach into those assets and take them. So that's it's a background issue, but that may explain some of the reasons or the causes for what you're seeing. The poverty may be they're just not prepared for their circumstance, or it may be because they haven't done proper estate planning and Medicaid is grabbing their assets
Oh,
and
absolutely.
and taking them.
Yeah, which is I want to say like the group of in their 80s, like late 70s, mid 80s, like that range right now, are really suffering from a combination of Medicare seizing their assets, new onset of chronic illnesses that requires a lot of investment, like just money investment, as well as things popping up. Like if they still own their own home and like all of a sudden they need a new roof, you know, they are like, oh, I can't afford that. It just becomes overwhelming for them because they are on a fixed income, because back when they were kids, it was like, I don't need to do anything. I don't need to invest. All of y'all, if you do not have an IRA, go start one. If you are working for the state, like I know a bunch of you guys work for fire departments and stuff, make sure that they are contributing to a 401(k) for you, which is the state version of a 403 or 401k or a 403b. Put money aside. You should. The younger you are and the sooner you do it, the more money you will have when you get older. Okay? Do it now. We'll have an investment talk at some point if y'all like. It would probably involve more wine, but we can do these things. These are things you need to do now, especially if you're going to start coming into medic money. It's also a really nice tax haven. So once you start making stupid medic money and you get to the end of the year and you're like, oh no, I'm going to pay so much in taxes because I worked 6 jobs and I pulled in 6 figures. It'll help. It'll help alleviate some of that Uncle Sam problem, okay?
And so also as an add-on to that, if you do in fact get into that position, you would see an attorney later on about protecting your assets from those issues that I'm talking about. So they have like legal documents, trust documents, and so forth. This is a little off topic, but you know, if you are encountering problems that exist, no, not see me. I don't.
But you must know a guy.
Definitely not illegal. I am seeing an estate planning attorney next week. That's why I'm mentioning it. But the fact of the matter is that you yourself can learn from the patients that you see about how it might
Oh
impact
yeah.
your life.
Oh yeah. Hugely. Hugely. Um, but yeah, if you have any questions about investing, or how to set yourself up, let me know. I'll do my best to help you. I'm not super good at it. My husband's very good at it, so I might just write off to him, for a small fee of a bottle of wine. Just kidding. Um, but yes, definitely set yourself up with a Roth IRA. Your max contribution, I believe, is 6,500. If you're in like your 20s, 30s, you can contribute more as you get older. Because the whole big thing that you really want to do is that it's going to compound interest. So as you get older, that money will be working for you and you don't have to do anything with it. And then you can retire a little more comfortably. So it's easy enough to set aside $6,500 over the course of a year. Trust me, do the math. It's like $180 a week. You probably spend more on Starbucks. Brianna, your facial expressions are killing me right now.
This is
Andrew,
like the first time that I have like financial advice, and my parents have been telling me to fill out a Roth IRA. So like it all comes together. I feel like
It
we go
does.
through so much in this class because like last week we did like a whole philosophical thing on like women's health, and now we're doing like financial aid, and I'm really okay with it.
Listen, this class, and like this is one of those things like when I first started teaching, I was like, this class can really have the opportunity to teach you a lot about life, because sometimes you don't want to listen to your parents about things, because sometimes you're like, I get it, you want the best for me, but I also kind of want a new car. So like that $6,500 becomes, a used car. Or you keep the car that you have that's kind of fine. You put $200 into new oil and new windshield windshield washer fluid. There we go.
Fluid.
I drove back and forth to Flushing today with two very squeaky windshield wipers. Squeak, 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 squeak. An hour and a half of squeaking. Anyway, Andrew, thank you for sharing your story. I appreciate that. Can you want to give us a little more detail? Like, feel free to say no, about your experiences.
Oh well, no, I was born deaf, and I had tons of surgery. I was born in England, Oxford, so I was born deaf. Had tons of surgery. I have autism, so I have just different disabilities, and it was just been a challenge all my life dealing with a lot of things. So I do read lips and I do know sign language. That's really pretty much it. So I tend to be very quiet, just observe and read people's lips, and
Cool.
yeah, that's really it.
Do you remember your sign language?
Yeah, I still know it.
Okay. Maybe you can in the future teach us some good sign language.
Or bad ones.
Or, I mean, I was going to put it in the context of patient care, but also I'm good with some good bad ones. Just saying.
Yes, that's fine.
I had a friend once who was on a rotation during my medics class, one of my fellow medics persons. They had a woman who was deaf, and she kept going like this. And they're like, "You have chest pain?" She's like, so she was trying to apologize. This is I'm sorry in sign language. She was apologizing for being a drunk mess, and they thought she had chest pain. So they couldn't figure out why she's going like this. They're going chest pain, and then try to put the electrodes on her. She's going. So the more you know. Yeah, we're gonna tap into you, I think, for some good, maybe a fun sign language tutorial. That's the word I was looking for. All right. Any other thoughts, questions, concerns before we move on to the last lecture? Now it's the TBI hitting, honestly. It's been a long day. I've definitely stood in front of the class going, I'm like, everybody's like, you okay? I'm like, nope. I hit a speed bump in my brain. Just like, terrible. All right, cool. Let's move on. Everyone's got their own little fun problems in life. come on, I want to share screen. Thank you. Lord. All right, more cheery topics, abuse and neglect. I'm just going to let you know that this is the lecture where you find all the abusers in your life and go, God damn it. Cutting those toxic people. All right. Abuse and maltreatment is considered an act or series of acts of commission or omission, so an actual act or a lack of action, by a caregiver or person in a position of power over the patient that results in harm, the potential for harm, or threat of harm to a patient. So this is an important kind of definition for you guys to understand because we are mandated reporters. So if you notice that there is something that a parent or a guardian is doing or not doing that results in the patient being harmed, then you are required to report it. For example, you have a patient, a young child, who is out in the snow in a t-shirt and shorts. Omission. The patient was not provided the adequate level of clothing, okay? Versus commission, where a parent strikes a child, okay? So keep these things in mind because, as I said, mandated reporters. There are a whole slew of different things that constitute abuse. Most of the time, abuse is kind of revolving around the idea of this person having power and control. And sometimes it's not always very obvious, okay? Sometimes it's like little tiny things that a person does that constitutes like abuse and violence. And again, it could be physical or it can be sexual, it can be emotional, it could be economic. Or it can be like a combination of all of these things that kind of build up into a larger problem. So, for example, the traditional brought to you by Law and Order SVU domestic violence abuse situation, right? So, most of the time, it's someone who is in a situation of power and wants to continue having power, right? So, in our scenario, right? Sorry, dudes, it's usually a man using his quote male privilege to define the roles in the relationship, right? So he is in that machismo kind of role. He's making his the woman in the relationship be subservient to him. He'll then move over here into economic abuse by preventing her from getting a job. So now she is economically reliant on him. And this is one of the bigger problems. People are like, oh, just get out of that situation, girl. Like, no, girl, she can't. Like, she doesn't have money, okay? Or you go the other way, down the ring, and he uses the children against her, okay, right? He's going to cause harm to those children if she tries to leave, okay? He's going to take them away or makes someone feel guilty, okay? There's a lot of different aspects of abuse and power and control that kind of play into this, and it's really challenging. And there's a lot of support that people need in order to get out of a bad situation, and the first step is recognizing that they're in a bad situation, because that's what happens. It's kind of like that gaslighting, right, where it's like, it's not that bad. I don't know why you think it's such a bad situation. I take good care of you. Don't I take good care of you, right? It's a problem, and it happens way more frequently than is like kind of okay. Different types of abuse or violence, I guess, is the intimate partner violence, right? Very common. People are in some level of relationship and they try to gain power and control over the other partner, okay? In New York State, if you are even dating someone, and you have a sexual relationship with that individual and they do something threatening, it's considered domestic violence, which now ups the ante in terms of like misdemeanor, felony kind of vibe. So you don't have to necessarily be married for it to be considered domestic violence. Intimate partner violence can constitute all of these things here: physical, verbal, sexual, emotional, spiritual, economic, right? all of these things. It could be primarily in one spot. It could be kind of evenly distributed. It's unique, unfortunately, to each situation. A lot of the problems with intimate partner is that people have a hard time seeing a way out because they feel powerless. They think that, they're made to believe that the situation that they are in is the best option. And a lot of people who are in abusive relationships may have come from another poor situation in the first place, right? We say in the child abuse section that abusers are frequently victims of abuse themselves. So people who find, and it's not 100% true with intimate partner violence, because sometimes it kind of sneaks up on people, I think, but people in bad situations frequently kind of frame those relationships in what they've seen. Okay, so if you have a child whose, father was a drug ahead who then beat their mother, it's more likely that she's going to end up in a situation similar because she's going to think it looks normal. Okay, it normalizes that. Repeated violence is terror. Okay, it's a huge problem in relationships, and that terror, just like terrorism, right? That we're like, oh, we're so scared, someone's going to bomb us, right? Same thing, but at a smaller scale. For the most part, women are more frequently seen as the victims of intimate partner violence. However, that does not mean that men are not victims of intimate partner violence. The problem primarily is that men refuse to admit it or seek help because there's that belief that they should be able to handle their relationship, right? We go back to that very male, like toxic masculinity, like, okay, you're in a bad relationship, no big deal, we can get you out. And it doesn't necessarily mean that it's all heteronormative relationships. There are plenty of homosexual relationships that are also like have a, let's call it, poor dynamic between intimate partners. Unfortunately, there are about 75% of women who are who are killed by those who are abusing them are murdered when they try to leave, which kind of just reinforces that idea that women who try to leave, there's a reason that women don't try to leave, is because it's scary, right? 75% of women are killed when they try to leave. The cycle of violence is very similar also to the cycle of abuse in any kind of situation, intimate or not. It starts with tension, okay? So there's something that went wrong, okay? Maybe you said something the wrong way, or you didn't have dinner on the table at the right time, and the abuser acts in this particular way that starts to build towards violence, right? So maybe they start slamming doors, they start drinking, they start name calling, or there's usually a pattern here. Then this moves into violence. This is the actual event, okay? It's either physical, emotional, sexual, right? Some sort of usually a crime, usually criminal, right? Because it's usually physical or sexual abuse. Because do not be fooled, rape within a marriage is still rape. It is still considered a crime. It's still a thing, still real. And then it can move into the honeymoon, okay? And this is usually, oh, honey, I'm so sorry. I only hurt you because I love you. Oh, let's do all the, like, right? And then there's this period of time where it's kind of okay, and maybe, the abuser apologizes, maybe, everything seems to kind of go back to normal, the bruises fade, and then we end up back in tension, right? Because we've forgotten. It's okay. It's not a big deal anymore. Oh, I didn't really mean it. So this is a very typical pattern seen in abuse as a whole. Go. Huge variety of reasons that intimate partner violence does not become reported. A lot of the times, even if the neighbors do happen to call the police on some sort of situation, the abused may not decide to press charges, which just extends the length of abuse. It could be that they believe it's normal, that they're trying to protect the children, or just fear in general, or denial that, the belief that the abuser's behavior will change. It never changes. Also, sidebar, for those of you who happen to still be single, please listen to my advice. Rule number 1 of dating: never redate an ex. There is a reason y'all broke up in the first place, okay? Trust that gut instinct, okay? Do not go backwards, move forward. There is maybe like 1 or 2 exceptions to this rule. One of them is like you're dating a military person and they're deployed and you're not, and you're like, let's just part on good terms right now because you're going to be busy killing uprisings in the Middle East. I'm going to be home. Let's just do our thing, and when we come back home, we'll see what happens. That's probably the only way that I'd be like, all right, cool, maybe give it another shot. Other than that, there is a reason y'all broke up. Thank you for coming to my TED Talk. I can't tell you the number of people I know who have been like, we got back together. Like 3 months later, they're like, oh, this is terrible. I'm like, I told you it was a bad idea. Anywho, back to men. 1 in 9 men has actually experienced severe physical violence by an intimate partner. That number is probably wrong, in so much as probably a little higher. It's just not been reported. A lot of humiliation and like guilt regarding their lack of manliness. It's a thing. Men can say no too. No means no, no matter what. Just like children who have like the same kind of or very similar characteristics when they're in an abusive relationship, people who are in abusive relationships, like intimate partner relationships, also have a very similar kind of pattern of characteristics. So they commonly have alcohol or drug dependence. As I said before, right, abusers or people who are being abused are typically caught in a horrible cycle of abuse. So they may have been physically, emotionally, sexually abused as a child, and now they're, either the abuser or being abused in their current adult relationships. Unemployment, low income, right, because now they feel maybe desperate for someone to take care of them. Antisocial behaviors, hostility. Unfortunately, being a member of a minority group, I don't know how much I agree with that one, because I think it's just that white people are better at not reporting stuff. How's that sound? Is that politically correct? Because white people are the ones who are going, no, I don't want to press charges. But not for the reasons of trying to keep their family together, but more for the reason of keeping face. I've watched Law and Order. Just like kids, descriptions of the injuries are probably wrong, right? What happened? Oh, I fell down a flight of stairs. Yeah, you do that on the regular? Because you look like you just went a few rounds with Evander Holyfield. Oh, no, I'm just very klutzy. No one that klutzy. Unless you got a brain tumor that's knocking off your equilibrium, you don't fall down the stairs once a week. It just doesn't happen. Intentional injuries, right? Bite marks, okay, especially like the breasts, bruises in various stages of healing, choke marks, right? Any sort of bruising around the neck, super suspicious. Any sort of like bruising or damage to the face. Pregnancy injuries, okay? Yeah, okay, maybe she fell down a flight of stairs because, oh, my balance was off because I'm like super pregnant. But maybe someone pushed her. Maybe there's some other issues, okay? Always have a high index of suspicion. Unfortunately, if you happen to walk into a scene at the wrong time, you may become the owners of brand new violence. It's happened. I've known at least 2 crews who have walked into domestic violence situations who have then become targeted by the abuser and had to call 85s and get cops there to help them out of the situation. No, there are really no real fault of their own other than the fact that, you know, they didn't scene safety really well. It was one of those, like, the fight was coming down the lobby, down into the lobby from the apartment, and they happened to enter the building at the wrong time. Don't confront anyone. It's not your job. We don't get paid enough for that. Go back to the ambulance. Scene is not safe. If you can bring the patient with you, then definitely do that. However, that does not mean that the person who is directing violence towards the patient will not either A, try to get into the ambulance, or B, now stalk outside of the ambulance. So you need to have good communication with your partner for the let's get the hell out of here portion of that scenario. I think there was a couple years ago, they brought up this whole concept that women who were the victims of abuse, if they called 911, they could put a black dot on the palm of their hand as a secret way of, like, asking for help. I don't know if that's still a thing. I would assume it's still kind of prevalent. I do know that there have been women who've used calling police for pizza delivery as a way to get assistance. Or called 911 and asking for pizza as a way for assistance. So don't be surprised if you're kind of dealing with something that you were not necessarily expecting. But you should try your best to get the patient away from their abuser. That could be a really hard thing to accomplish, because remember, abuse is about power and control. And it could also be like, sometimes it's a cultural misinterpretation. Like, I've definitely walked into, like, Bengali houses where this woman is having, like, a medical emergency and her husband is speaking for her, even though she's perfectly capable of doing it. I'm sorry, I got distracted by Brianna's sugar glider. So sometimes you need to maybe, like, parse out what's abuse and what's culturally appropriate and what maybe steps over the line of culturally appropriate into abuse. It can be sticky. Just be cautious and make sure that you're protecting yourself and your partner before anything else. There are certain, come on, share. You, don't be judgy, okay? Don't judge. Like, oh, you know, you really need to get out. No, just be supportive. This is the time for you to be the agent of change. This is the time where you have more power as an EMS provider than you think you do. Okay? This could be telling the husband that you're going to one hospital, but bringing her to another so that she has maybe some time to speak to social work. Okay? This could be, you know, changing direction when you're in route so that she has an opportunity to maybe do something, or making sure that there is a social worker for her to talk to when she gets to the hospital, okay? Or, you know, demanding that this gentleman or this lady, whoever's the abuser, is not going to be on the ambulance, okay? You can do those things. Use COVID. It's a great thing. COVID excuse. Can't take you. Sorry, COVID. Other legal considerations, right? So, in New York State, we have assault and battery, which is kind of put under one umbrella rather than in other states where you can have assault and you can have battery. Assault is the threat. Battery is the actual hands-on action. You need to make sure that you document appropriately, because if this does happen to escalate, you may be called into court. So this is one of those times where really, really good patient documentation is necessary. You should have just a pristine ACR. Quotes of the patient if possible, okay? Describe the injuries and how the patient tells you that they received them. patient abuser, the patient's behavior, the abuser's behavior. These are all things that can be like put into your ACR in a non-judgmental, unbiased way that provides a third-party account of what's going on. So again, you have the power for change. Moving on to the elder and vulnerable adult abuse, we talked about this a little bit in the geriatric section. We're just going to go a little brief overview again. Again, if you were abused as a child, you are more likely to be an abuser as an adult. Excuse me. Also, if the patient happens to be a caregiver very early, right? So maybe somebody's parent has MS or has ALS or has some sort of debilitating disease where they require a younger child in their early teens or younger to sort of step up and be the head of the household, right? That can promote a lot of resentment and kind of not necessarily allow that person to develop adequate coping skills, and just creates like a situation, like an emotional situation where that person starts to really not be okay. A vulnerable adult is anyone over the age of 18 who has an impaired ability to protect themselves. This could be in the home setting or in a facility setting. This could be a cognitive or a physical ability to protect themselves, right? So a patient with really bad dementia does not have the ability to say, hey, that's not okay, or like ask for help. Whereas a person who is physically incapable of protecting themselves, right, has a different set of scenarios. For the most part, patients who are in their home, who are victims of elder abuse, tend to be over the age of 78, are primarily women, primarily widows, and are usually neglected, okay? There may be like some sort of like physicality aspects of it as well. But the more sick a person is, the more likely they are to be a victim of the elder abuse, because it becomes too much for the person who's the caretaker. And there's this huge push in the United States to sort of shift elder care back into the home rather than facilities. And facilities are no real, palace. But there are people who are just not equipped to be caretakers. Like, there's plenty of people who just should not have another human being in their care. I think we all know those people. So that's the problem. And like, then on top of it, you add this extra layer that if that person who's caring for that geriatric patient happens to be their son or daughter or grandchild or niece or nephew, that familial relationship develops this level of guilt where they're like, oh, I don't want to get them in trouble. Who else is going to take care of me? Like, it becomes a problem. It's highly underreported due to that. Abusers are just a hot mess, frankly. They kind of believe that violence is the way to solve problems, or get what they want. Kind of going back to that power and control situation that we talked about earlier. And it's very personality dependent. Abusers can be narcissists, right? They want recognition. They want someone to tell them that they've done a good job, or, oh, how wonderful it is that you take care of your mother or the sick child or this, that, the other, right? They want someone to make them feel special. That's an issue. Okay, and I get it. I get there's some people who really need that, like ego stroke, but when you're taking care of somebody, or you're a caretaker of the elderly or a sick child or just any old child, you have to kind of set that aside. A lot of times, another aspect of especially elder abuse is the economic factor, where Social Security checks will go missing, medications might go missing, right? So grandma's pain medicine's gone wandering off. It's multifaceted and it's a big problem, and there's no simple fix for it one way or the other, unfortunately. Institutional elder abuse, on the other hand, could probably be fixed if we stopped hiring any old person and maybe paid them a little bit more so that they had a better appreciation of the job that they did and allowed them more time off as a whole. P.S. If you have PTO, this is your reminder that we are in the final quarter. If your PTO does not roll over, you should use it, Danny. Anyway, this is about 2-year-old information. There's 1.4 million residents in nursing homes in the United States, which is probably not 100% accurate anymore. Remember, we are in what's called the graying of America, where we have the baby boomers who are all starting to hit their 60s and older. So if they have chronic issues or they have some sort of, need for a regular care, they're going to be potentially ending up in nursing homes as well. Residential care facilities, right? So you have like that assisted living, which P.S. there's definitely some assisted livings that look really fun. But this puts all of those patients at a high risk for harm and for abuse. So again, if you happen to be in that transport 9 or EMS situation, there's a lot of clues that you really should be kind of looking out for because it's a strong possibility that you will encounter institutional elder abuse more than everyone else will encounter domestic elder abuse, or at least it'll be potentially a little bit more obvious, unfortunately. So we're going to talk about numbers real quick. So 2016, CPS investigated around 3.5 million reports of potential child abuse. Of those, so that's 3.5 mil, just over 500,000 were substantiated. Okay, so that's 3 million, this is easy numbers, 3 million were bullshit, 500,000 were real, and of those 500,000 substantiated claims, about 1,700 children died. That's too many children to die. I'm sorry. And we see this on the news, I feel like, very frequently, where it's like, CPS was at the house like last week and now the baby's dead. And you're like, what were they doing? Like, why is this child still here? Did anyone see about the car accident in Brentwood, where mom was drunk and drove straight up into a house with her 2 kids in the back? So the custody of those 2 children went to the father, and my mother was like, how dare they give the custody to the father? I'm like, where would you like these children to go? They have a custodial guardian. They have a parent. They're in their home. Like, he didn't do anything wrong. He wasn't in there, like, with a funnel feeding her, like, tequila shots. Like, he was not involved in the situation. Would you rather separate this family because mom did something stupid? No, mom should be thrown in jail, and that's the end of it. Like, she screwed up, he didn't screw up. Not to be like rah, like he potentially doesn't have problems, but is it better to take a kid away from their family, or is it better to? It's a hard situation. But when you have both parents who are doing wild and crazy abusive things, and we leave the child in the freaking home, it breaks my heart. Poor kids. There's a lot of, what am I doing? There's a lot of kids who probably never needed to die. There's another rabbit hole if you really want. 60 minutes.
The trial of Gabriel Hernandez.
There you go.
Oh my god.
Terrible.
I binge watched that in probably like 2 days, and I was just like so shook at how like blind all these people are.
So, hold on. Oh no. Going back a little bit, it's also sometimes it's really hard to detect child abuse, because I think part of the thing is like, if these people, so the whole characteristics of an abuser is that they're sort of socially isolated. So that means that they're not hanging out with grandma, aunts, uncles, and nieces and nephews at the barbecue on the weekend. they're doing kind of their own thing. They're very insulated. And when you send these kids to school, sometimes a lot of those clues are missed because the teacher's got a class of 30 and they're wondering about this one who's pulling their pants down and this one who's gluing their classmate to the chair. It becomes challenging, and like just because the kid is quiet doesn't necessarily mean that they're being abused. So it's this wider systemic problem, but it just boggles the mind.
And then I don't think CPS is like a government thing. They're third party, right?
I'm not sure.
I think they're third party.
I just know that some of the people who investigate are not some of the most together people either.
Yeah.
Which, yeah, Darius is right. They're underfunded. Most things in the United States are underfunded.
CPS is usually a third-party contractor, but authorized under statute, and they have statutory authority, but they're usually operating under some contract with the state because the state doesn't have the infrastructure to deal with it.
Shocker. We don't have the infrastructure. Darius, one day I'm going to make you talk on this. I know you're my quiet person, but you know a lot of things. You're allowed to share, I promise. All right. So yeah, back to depression. Child abuse really does span kind of the whole variety of people and economic classes, and I feel like going back to the CPS thing, I feel like it really targets, or the things that we see on the news happen to be like these people in the projects and these people in the NYCHA housing had like, babies strung up from the ceiling, and you're like, what about like, the people who lived in the house that had the fucking basement that was also a dungeon, but their house happened to be like in a really nice part of town where like mom was a lawyer and dad was a doctor, and like their kids just had no eyeballs anymore because they were strung up from our freaking rafters. Like, sorry, let's media narrative issues. Yeah, so you should have a certain level of suspicion, kind of regardless of what you're walking into. Don't be that guy, okay? Most of the time, child abusers happen to be the child's mother, and most of the time the child's mother happens to be the one who's with them most of the time. The person or the family is socially isolated, which we talked about already. Substance abuse, mental health issues. But let's rewind, like Be Kind, rewind. Let's talk about, what was it, Idaho? The mom who had the daughter and the son. Her son was autistic, and she had a brand new boyfriend, and she killed her 2 kids and got remarried, and then flew off to freaking Hawaii and had to be extradited from Hawaii. So does she fit any of those characteristics? Not really. Like, she wasn't socially disadvantaged. I don't remember the rest ones. She, yeah, well, she's kid's mom. She wasn't socially isolated. She had all this family, all these people who are like, where the hell are your children? She's like, they're fine. They're dead. They were dead. They just did a 60 minutes on this, or 48 hours, one of those things. And they like dug up the backyard and found them. I'm like, that's horrible. Like, it took a few months for them to find these children. Just boggles the mind. Like, people are messed up. Like, wildly messed up. And here in EMS, we just develop really bad, dark coping habits. Again, characteristics of abused children: if they're less than 6, they usually are very passive. When they get older than 6, they're very aggressive because they just don't know what to do with themselves. Kids who don't care if their parents leave the room, especially the younger children, right? Because younger children are very like, where's mommy and daddy going? Cry inappropriately, very apprehensive, are very knowledgeable of sexual terms when they're very young. it is unlikely that a child is being abused if they're the ones who are like, this happens, like, or this happened. Like, I was riding my bike and I was going down this really big hill and I hit a bump and I flew off, and they have like weird injuries and they're like, yeah, no, he totally took that, tried to take that bump. Like, kids kind of like are very honest, right? They're not gonna, it takes a little while to teach a kid to lie, especially when they're younger. Here's your child abuse hotline number. You are a mandated reporter. Again, make sure your documentation is thorough and appropriate. If you don't, there's also a form that goes along with this that you really need to fill out. Definitely read it through the first time that you're filling it out. Hopefully you don't have to, because that's just depressing. Hey, Brianna, here's your answer. Common injuries of abuse, soft tissue. Fractures are a little less frequent because, as we said, their bones are a little more rubbery, so it takes a little more force in order to create a fracture. So while soft tissue injuries are the most frequent, fractures are the most suspicious. Head injuries are usually how kids die because, again, they kind of will compensate for a period of time. Blunt injuries to the abdomen, again, very commonly lead to like liver and spleen ruptures, which can cause serious hemorrhage and cause all sorts of other issues. Shaken baby syndrome, okay, this is usually a relatively new parent who is incapable of handling stress, okay? So baby won't settle down, and then usually it's unfortunately a male because it's that extra level of like frustration and strength. Then they shake the baby. Remember, big old pumpkin head, not a lot of neck muscles. That head goes backwards and forwards and backwards and forwards, and the brain bounces back and forth inside their skull, leading to various brain bleeds, usually subdural hematomas, and brain swelling due to the bleeding and just overall like damage from the diffuse bouncing back and forth. Scalding, right? Anywhere where they have the, especially where they have that sock injury, right, where they put the baby in very hot water and dip them in. Starvation, dehydration, which are really probably some of the most horrific long-term kind of abuses that you're going to see, which is just, again, heartbreaking. Supervision neglect. We talked about commission versus omission. Supervision neglect is an omission. Most neglect is omission. Okay, there was an adult who should have been doing something and they failed to do that. This is the kid who falls out of the second-story window. Chronic neglect is the kid who's never fed. Physical abuse, right? Various assaults. All of these things can be chronic. Sexual assault, 60% of assaults are not reported. Again, not super surprising where 60% of assaults, you know, are just, there's just a victim shaming culture in this country where it's like, oh, well, what were you wearing? Let me tell you what you were wearing. This patient, and there's an artist who actually collected the shirts or the clothing of rape patients or victims to kind of dispel the notion that you were quote unquote asking for it. Okay, a lot of women who were raped happened to be in the wrong place at the wrong time or were victims of date rape, right? And they weren't wearing something ridiculous or out of control. It was a t-shirt and jeans. Okay, they just happened to maybe be by themselves or vulnerable. But again, it shouldn't be the forefront of every woman's mind that I shouldn't be in this place. I shouldn't be in this scenario. Why is it that we don't expect men to be respectful of women and their ability to say no and their ability to consent? Like, why do we have these awful human beings out there who just want that power, control, and that it's just terrible. We're not going to go into that one again. So in the state of New York, rape is considered a unwanted vaginal penetration. So when a male victim cannot be raped, technically. It's considered sodomy, and again, forcible, unwanted sodomy. Overall, sexual assault is any sort of manual penetration of an orifice that is unwanted. You need to bring this patient to a safe hospital sane hospital, sorry, because there are specially trained nurses who are going to collect the evidence that is necessary. Again, remember, do not let the patient change their clothes. Do not let them brush their teeth or shower or anything like that, because it's going to remove evidence. There was one state recently that actually finally fixed their backlog of rape kits, going on about how we need to fix problems in this country. Why is it that we have a backlog of rape kits? If 60% of sexual assaults go unreported, why do we have rape kits sitting on a shelf from years and years ago? Curiosities. Things that don't 100% make sense. God, I keep hitting the wrong button. All right. For the most part, people actually, unfortunately, will know who their attacker is. This is why we don't, ladies, gentlemen, this is why you don't put your drink down unsupervised. This is why you don't go places without a backup plan, or a friend, or a code word to a friend to come get you, because people are terrible and unpredictable. Commonly, injuries that you see in sexual assault patients are abrasions and bruises, bites, injuries. It could be a lot of defensive wounds as well. Depending on what has happened in the situation, there could be inexplicable muscle soreness, where a patient has been drugged and they don't understand why they're sore. The muscle soreness is usually associated with some level of restraint that has been applied to them in order to make them more vulnerable. Cool. Thank goodness. That depressingness is over. How's everybody doing? Hope we're drinking happy drinks. Good? Bad? Indifferent? Okay. Questions? Yes, no, maybe so?
How hard do we need to study in this section?
Stand by 1 second. Hold on.
On my BLS rotation, we had to call for ALS, and his BP was 230 over like 120.
Oh yeah. Oh, absolutely. I've seen I think the highest I've ever had was like 290 and over change. So it can get really high really fast. So how would you treat him?
Nitro.
No.
Chick, I'm gonna come smack you.
Yeah, no nitro.
No
It's blood
nitro.
pressure.
No nitro.
So you got to treat what he's presenting with. So respiratory distress, he's got to get oxygen.
Okay, so
CPAP.
let's put this in O2. How?
High flow, non-rebreather.
EKG as well.
We might go with CPAP depending on the circumstances, but that could drop his blood pressure as well. So we want to kind of, leave that in the background.
I'm gonna go with. So CPAP is kind of one of those cool things. So like if you were using, so you have so you have APE on this end of like hypertensive, and then on this end you have CHF, which is just for all intents and purposes, let's say is like more normal to hypo.
One is chronic and the other one's acute.
So the cool thing about CPAP, let me just change this color for
We have to watch for the airways as well
influence.
because of the sputum and everything else.
Wait,
CPAP may not be
what
able to
else?
work.
What else? So right, yes, you said sputum, yes, but what else is important about this description of the patient that you're like, hey, I'm worried about this airway?
His mental status.
His mental status, right? Because he's delirious. Very good pickup. So going back to CPAP real quick, the really cool thing about CPAP is if you put on a patient with APE, it will bring the blood pressure down. If you put it on a patient who's in CHF, it'll bring the blood pressure up. Because basically what you're doing is you're bringing like the equilibrium to the whole system.
Okay.
Okay, but
So, but he's delirious.
He's delirious. Exactly. So going back here, he's delirious. So that means that CPAP is unfortunately knocked out of your plan of treatment.
Okay, so staying non-rebreather,
Mm-hmm.
no CPAP because he's not compliant, and now we have to put him on the EKG. Did we already do that?
Yep, he's right here. This is your strip.
All right. So he's in a. Let's assess the rhythm. We have a 1, 2, 11, 12. It's at least sinus tach.
Okay.
And I'd go with a rate of about 120.
All right, so let's do the rate real quick, right? So here, right here in this section, we have this bad boy falls right on. This is 300. There's 150.
Okay, so 150. So he's on the borderline with SVT.
Mm-hmm.
So hemodynamically stable. We might want to consider at this point, and he's allergic.
He's allergic to Lasix.
Okay, but we could go with a calcium channel blocker. He's already on that medication.
But let's go back to what was his blood pressure? Did anyone remember?
Blood pressure 112.
112 over, I think, 82.
Right.
Would you
don't want to lower his heart rate then?
Yeah, so all right, so let's go back to talking about this heart rate. So he has a heart rate of, let's call it 120 to 150.
Okay.
Is this compensatory or is this SVT? So let's go compensatory.
I'm going to say compensatory given his blood pressure. I mean, it's low, but given his health condition and what's going on, that seems more compensatory.
Okay, so his blood pressure. So can you have an SVT that has a decent blood pressure?
Yes.
Good. Can you have a patient who's delirious? Oh, and has a decent blood pressure and is an SVT?
Possibly.
Possibly. What else is going on with this patient that should be a little red flag to you that like, hey, this 120 to 150 number that I'm seeing is...
He's pale and diaphoretic.
Okay, so what does pale and diaphoretic to you mean?
That's compensatory. That's showing some sort of shock. And that he's, even though his blood pressure doesn't show he's in shock, there are other indicators that he is.
Okay, so let's talk about the shock right now. Okay, so what shock? What do you think is going on in terms of shock? What is causing his
it's cardiogenic
hypoperfusion?
shock? Cardiogenic. There's something going on with his heart. He's not getting adequate oxygenation to the rest of the body. It has something to do with the fluid in his lungs as well, but that may be secondary to the heart not doing what it's supposed to.
Okay.
And he's jamming up the fluid in the lungs.
Anybody else? What other
shocks? But he's also using his his respiratory as well. So he's his muscles, and there's an increase in coughing and all the sputum and everything else.
All right, so hold on. So we got sputum, right? We've got coughing. What else?
Lava, back pain.
Rails up to the nipple line.
There you go, rails. So we talked about this a little bit in the respiratory, right? So if he's got rails, what other lung sounds kind of hang out with rails? or could mask the lung sounds?
Bronchi?
Bronchi.
Beautiful. Now, when you look at rails, what do you usually think?
Fluid.
Fluid. When you got bronchi, what do you usually think?
Mucus.
Is there like a middle ground that this could potentially be?
Pneumonia.
No, normal's like over here, like looking at like everybody else, like, oh my god, gross. My sad face. Bleh. So
Well, is he wheezing? No, wheezing.
no wheezing, but what other don't answer right away because Brianna had a question. I want to get to that. But what other shock or what other potential shock-y? Because I won't even say he's not shock yet, but he's getting there. What other shock-y states are there? Brianna, what was your question?
So, when I was on that call in the Bronx, the FDNY medics gave nitro.
Mm-hmm.
Is there any reason why they would give nitro over anything else?
So, yes. One, let's go to the, oh, hold on. Let's go disregard everybody who's going on right here.
They were also kind of major dicks. I don't like.
That doesn't surprise me.
They were just very rude.
Again, doesn't surprise me. Me and I have minimal respect for most FDNY medics. If I know you, I'll respect you, and you have to prove it. All right, so.
But they were rescue medics too,
Oh,
so.
Lord, the ego must have been like bigger than the truck. So,
yeah.
When, I don't know if you can see through this, I hope you can. So the patient that you had when they had a blood pressure of like 280, they were treating the patient under the acute pulmonary edema. You know what? Screw it. Let me just clear this up for you so it's just easier to see. Maybe. There we go. All right. So they were treating that patient under the acute pulmonary edema protocol, which we've kind of already ruled out as an option for the patient in this scenario. So basically, one, BLS life support. What's your BLS life support? Oxygen. Cardiac monitor, 3 lead and a 12 lead. Okay?
Mm-hmm.
Because you're going to make sure that the patient is not having an MI. Because if the patient's having an MI, then you're going to go say, oh, it's a STEMI note, right? And then you make money for the hospital and everybody loves you. Monitor your vital signs every 2 to 3 minutes because you're going to be giving nitro. So the cool thing about when you give nitro, so you have this heart. Where's my sad heart? There's an issue with the afterload, which is the external side of the heart, right? So you have blood coming into the heart, blood going out. So you have your preload and you have your afterload. Okay? So there is something on this, usually on this side of the heart, that's restricting the heart from pumping against all of the pressure in the body. It could be that the heart is having an MI. It could be that there's a fluid overload, right? Because it's usually accompanied by CHF. It could be any number of things. Right. So basically, when they're giving this patient the nitro dilates, right? So everything in the entire body is now open. So you are reducing your afterload so that the heart doesn't have to pump against as much pressure. So that's going to make it easier for the heart to pump, and that's going to take the fluid out of the lungs where it's backing up to. Pretend those are lungs. So where the lungs are like filling up with fluid because it's backing up from the heart, once you start dilating it and reducing the work to go this way, the fluid can go down inside the lungs. Now, CPAP works in a similar way where it starts to, instead of working on the heart directly, it starts working on the lungs. And it starts pushing everything out. And as it pushes everything out and creates this pressure inside the lungs, it pushes everything backwards and backwards. And it starts to reduce, or it starts to improve the oxygen. So the heart's not screaming for oxygen. There's this heart screaming, oh no. There's a heart screaming for oxygen because it's being pushed full of oxygen. And it's also because you're increasing the intrathoracic pressure.
Mhm.
It's restricting how much blood can get into the heart, which means that you're now reducing the preload. And if you reduce the preload, you reduce the afterload.
Right.
So, one, you're increasing your oxygen, you're decreasing your preload, which thereby decreases your afterload. So the heart is like happy because it can get some oxygen. It's happy because there's not as much pressure to push against. But not every patient can get CPAP because a lot of patients have a hard time tolerating it. If they're delirious, like in this last scenario, right? So you're essentially attacking this problem via two methods, right? So here and here. Frankly, depending on where you are, I would not even bother calling medical control for Lasix.
Yeah.
Because Lasix takes about an hour to kick in. You're
Right.
not going to be displacing enough fluid in that time, unless you are in Breezy Point and you're transporting to Jamaica Hospital because it's a STEMI. You're not doing anything. You have the potential here in this medical control option to administer sedation because as the heart and the body is screaming for oxygen, up goes the anxiety. Which means that it's going to be harder to get the CPAP on because the patient's like freaking out. So as a patient, if you give them a little, you should midazzle them a little bit. This is one of my favorite, midazzle. If you give them a little midazzle, they'll calm down and you can get the CPAP on them and fix them in the grand scheme of things. Now, what's your patient's blood pressure? So if you had a patient who had a blood pressure of like 280 over 120, and this is off the books, okay? This is not official. This is one of those quote-unquote critical thinking. Your plan here is I'm going to give nitro and I'm going to put CPAP on. How are you going to give nitro every 5 minutes if you've got a mask on their face?
Right.
So, not saying this has or has not been done, but you take maybe 3 or 4 nitro, chuck it in the patient's mouth, and then slap the CPAP on them. You have to be really careful watching their blood pressure. Over here at number 4, every 2 to 3 minutes. But one of the kind of interesting things that you see with APE is that the patient's mucosal membrane is very dry. If you have very dry mucosal membrane, is your sublingual medication going to be effective?
No.
And this is unofficial paramedicine. Cowboy hat fully on. But and I'm not going to say that I have not done that. I've totally done that. I think I had a patient whose blood pressure was close to 300 and I took like 5 nitro and it's like, and then shoved the CPAP on his face. He definitely swallowed at least one of them, like just full right back. I've also taken the CPAP mask, put it on appropriately, and then like took my finger with the nitro and gone, stick your tongue out, and like had them do like one of those. Not as effective. But the best part about CPAP is once you get that mask, like that seal on that mask, they're going to be good in like 5 minutes. Their blood pressure should come down. The problem is when you get to the hospital and then they're like, why is he on CPAP? And like take it off and you're like, just like every single time you put on a traction splint, you go to the hospital like, what's this? And like you're like, oh, we tried so hard. Okay, so just critical thinking. Don't ever put that in a Scott scenario. He might actually explode. Okay? Just throwing that out there. Okay.
So back to our patient
Back
with
to our patient. Hold on.
yeah.
Son of a. Go away. Go away, little toolbar. All right. So, so we talked about this already. We talked about we got CPAP. Is not going to be good because he is delirious. We're going to give him oxygen by non-rebreather. Is there anything else? And the 3 leads. So we have O2, non-rebreather. We've got 3 lead. We've got a 12 lead. What else? Anything?
We were at the question of whether we go medicine or Edison or anything with the heart rate, and whether or not he should be getting anything for the heart rate in his condition.
What is the best thing with a patient with a normotensive blood pressure, questionable rails, that you would consider?
Rapid transport.
What?
I said rapid transport.
Yes, definitely rapid transport. I'll put that one on top. Rapid transport. What other medication-y treatments would you be potentially?
Benadryl?
No, not Benadryl.
No.
No. What else? Think super basic, but still ALS.
Combat vet.
I won't rule it out. Combi.
What do you say?
Combi vent.
You're talking
maybe
now about you're running
Solumedrol, a corticosteroid, something like that.
All right, so you're talking about just going to the asthma protocol, but I mean, is that really appropriate with all the fluid?
Nicole, can we give ipratropium without the albuterol?
No, you can give albuterol without ipratropium. You can't give ipratropium without albuterol unless the patient has pretty much taken an entire inhaler at home.
So we could go albuterol, ipratropium, bromide. You say that would be the way to go?
Not necessarily. I'm just putting it down. So like,
Okay.
This is for conversation points. So, do we want to use like the asthma protocol?
No. She got wheezing, but I mean, it's in there, diffuse wheezing.
Okay.
It's possible. It's suggestive, but there's a lot of fluid in there. So.
But is it now? Okay, so now let's go back real quick. So if he has some level of wheezing,
Right.
Can you give one combi vent and see if the rails
Sure, absolutely
get worse, or go to Ronchi, or the rails go to death, worse?
I mean, the wheezing is there. Wheezing would suggest that yes, it's in the protocols.
Okay, good. How do we feel about Solumedrol? Because I like Ashley's suggestion. Solumedrol.
I was just thinking, if he's having trouble breathing, it sounds like there's some type of infection. His airway, his lungs are probably inflamed. So I was just thinking, like, yes, it takes a while to work, but it would help in the long run. Like, yeah, that was kind of my thought process towards it.
Yes, so it works under a number of protocols. So it can work under your asthma protocol, right? So you're like, yeah, we treated him under an asthma protocol. We gave him the combi, we did the Solumedrol, and then after we gave him the combi, we noted that he had Ronchi, and he was hot to the touch.
Okay, so Nicole, can I throw in here, is this cancer suggestion in here that he's undergoing chemotherapy, is this active in this scenario?
Yes.
Because I'm thinking that it is at this point. And in fact, giving
chemotherapy 1 week ago.
Okay, so then I think what we have is a chemotherapy reaction, and the Solumedrol is probably an excellent suggestion.
What else? So wait, before we go beyond this point right here.
Sure.
What else does chemotherapy do that would kind of expand your view, because it was on you were on the right track in the list of differential diagnoses we originally had, which was pneumonia, sepsis. There's one more, just infection in general.
It weakens the body's immune system.
Perfect. Perfect. This patient is an immunosuppressant patient, suppressed patient. Is Solumedrol, thinking of like this, think of COVID, Solumedrol and or Dex, because we have Dex in the protocol and the unified, will that help a patient who is immunosuppressed and maybe also has an infection? So what's our signs right now? What are our signs? So let's clear this. What are our signs that this patient has an infection? So let's just write this here. So we have an infection, right? In your context clues right here. What do we got?
Well, you have the sputum.
Okay, so we got sputum.
Which suggests that
it's white though.
Shivers.
You can have white sputum. It's still an infectious process. Think about pus in general, right? Pus is still white, depending on where that sputum is generating from. The older that sputum is, the yellower or darker it gets.
Solumedrol is an immunosuppressant as well, so that may cause additional issues.
Yeah, so Solumedrol, though, or steroids, in the emergent setting, stabilizes the cell wall. And this is why that first preceptor didn't like me. Hold on. I'm just going to fix that because that's stabilizes cell wall. So if you have like a number of like cells kind of just hanging out, and you've got like this one guy over here who's like, I'm infected, right? So like this is how infection spreads, right? It goes from cell to cell, cell to cell, and it piggybacks. So if you give Solumedrol, right, and the Solumedrol comes in and is just like, hold up, I see what's going on here. I'm not okay with this. Let me stabilize this cell wall here. It's going to prevent that spread. Okay, so it's a possibility that it could be particularly useful, especially in the earlier stages. Like that's part of the reason that they're giving the dexamethasone to COVID patients, because they want to stabilize that cell wall so that it doesn't allow the virus to kind of confetti all over the rest of the body, because nothing's worse than viral confetti. But going back to our context here, what other concerns or what other context clues in this scenario are shouting to you, okay, oh yeah, maybe it's an infection?
Shivers.
Shivers. This state loves shivers. Loves shivers.
Two possibly you could throw in there.
Which one?
Back pain could possibly be a sign of that as well.
Yep, absolutely. Especially if you have a patient who's got pneumonia. Sometimes, especially in the older patients, it'll be like back pain or nausea. It doesn't necessarily initially present as like coughing or fever. Okay, I've seen pneumonia pop up as abdominal pain. So
increased confusion.
What's that? Oh, increased confusion. Yes, yes. So this right here, the increased confusion portion of this, should start leading you down the we're going towards sepsis direction. Okay, so if we go back and look at our protocols, so I think that's good, everybody. Let's see.
Severe sepsis shock.
Severe sepsis, septic shock. So, does this patient My little pen go. Come back, pen. Does the patient in our scenario display signs of inadequate ventilation?
Oh, the epi.
Affirmative.
What?
No, I'm just looking down below at the epi, but
Oh, hold on.
I don't-
Let's go to Appendix U.
yeah.
Right? So Appendix U gives you your criteria. Oh no, I don't want that. Go away. Let's see. In case you guys aren't sure where this is, NewYorkCityRamsco.org. Son of a bitch. Appendices, thank you. It's not what I wanted at all. That's news and announcement. There we go. All right. Appendices. Not the most user-friendly. And again, remember this is from September 9th. So are we gonna download? You're just gonna giggle at me. There we go. So let's look for Appendix U. There we go. Criterias. So on our list of things that our patient has as a problem, blood pressure. Is it less than 90? Or map of less
No.
than 65? No. Heart rate greater than 110?
Yes.
Yes. Respiratory rate greater than 30 or end tidal less than 30?
We were at 30, I think.
We were close. So I'll hold that one over here. Put that there. Temperature. Is his skin tactile, fever, or hypothermia? Back real quick. Oh, it's not going back. It does say that he's hot to the touch. Does he have an unexplained altered mental status?
Yes.
We don't have point of care lactate because we're not that cool. So, at least 3 of the following must be present. And then going to what you were saying, Joe, before, that he's in that shocky state. Is it cardiac or trauma?
It's not trauma.
It's not trauma, so we crossed off trauma. Still a possibility that's cardiac because his heart rate is very elevated. But we also have that it's that he's warm to the touch and he's AMS.
Right.
So that means we get to go play in that protocol. So let's go. Oh, for the love of God. So going back to the sepsis protocol, right? We can do BLS, which we've done. So we've done BLS, right? So we've gave him oxygen. We've put him on. We haven't ventilated him yet because he's still hanging in pretty good for us. One thing that nobody said was an IV. Y'all are just not doing IVs today, I guess. 16 is my personal favorite. You can give up to 2 liters. Oh, 2 liters via macro drip. Okay. This is really for when you pick up patients from the urgent care and they're like dying and the urgent care did jack shit. They put in like a 22 gauge and you're like, what is this? Cardiac monitoring, we said 3 lead and we said 12 lead, so we're good. We did that. We don't have the ability to do this because we're just not that cool. We have this now, which is fantastic, right? We can take everybody's temperature because COVID. Now, what's your transport decision?
One stable rapid transport.
Yep, those the Jonies have rapid transport. Where do you want to go?
closest facility.
Is there any specialty facility for sepsis?
Not that I'm aware of.
Trick question. Correct. All right. So now imagine you get to this patient and his blood pressure is 80/40. He's hot to the touch. His heart rate's 150. He's AMS. Is this a little clearer that he's septic to you?
Yes.
Okay. So just
That's already getting into the later stages.
oh yeah, he's over here in the sad face. But the thing is, don't wait for your patient to get here. If your patient's 112/80, that's fantastic. You can work with this. This patient will have a much better outcome than this patient. Okay? This is a matter of recognizing and treating him. Now, this says right here that we can give this gentleman 2 liters of normal saline or lactated ringers. Do you want to give him 2 liters of fluid?
This patient, no, that's a bit much.
That's a lot.
I mean,
much.
given the presentation of the fluid in the lungs, yes,
yeah,
too
so
much.
he's got lungs and he's got pedal edema, right? So he's definitely got something else going.
How does, and I know you're getting to it because I'm just chomping at the bit here. So you're talking about the asthma protocol and the wheezing, and now I see the epinephrine. So, pulling that out into the mix.
All right, so
and heading into shock land.
All right, so don't be fooled by this epi here.
Okay.
This is 1 in 100,000 epi.
Right.
So you're taking your cardiac arrest epi.
Okay.
All right, you're 1 in 10,000. Right, so you're putting 1 ml. Hold on, 1 ml of 1 in 10,000 epi into 9 mLs of normal saline to create something called push dose epi. Okay. Push dose. Push dose epi is a stand-in for when you are not able to do norepi or dopamine. It's another vasopressor, right? So all those 3 guys kind of hang out, right? So you have your epi, norepi, and dopamine that all hang out. Push dose epinephrine has been proven to be very effective for a variety of shock patients because of its kind of systemic effects. If it was me and I was treating a patient especially a patient like 80/40, I would be calling for norepi because it's proven. The literature says that norepi is really good for septic patients.
Okay. All right. So basically, in this, and by the way, this is exactly what I think we need to be doing as a group, spending time on these case scenarios and going through it and working through what's right and wrong. But if you could, I mean, I don't know how we work it into your busy schedule. Like if we do a couple of, 2 or 3 or 4, maybe during the holiday of protocol / case study scenarios, or just pulling one out. It doesn't have to be, I mean, I think one of these, this gives me such a greater understanding of like septic. I mean, I've talked to so many medics who say, don't, zebras versus horses. Okay, sepsis. They keep telling me over and over again. You see a call, you keep thinking it's like a zebra and it's a horse.
Oh yeah.
And I'm sure everybody gets that reference, but just this right here, it's like bam, I get it. Sepsis. This is where we're at. The IV with the fluid, with 18 of us in the room and nobody suggests it.
You know what? And it's not your guys' fault because, again, you don't have that foundation for where we kind of threw protocols and we threw cases, like patient case scenarios, and you're actually on the ambulance in a significant fashion because this really starts to click when you're and you're seeing it in ALS. Again, like, you can go in and see as many plastic mannequins as you want. It doesn't replace you walking in and seeing a patient laying like this with their mouth like this making that noise. And you're like, oh, he's septic. Like, you know what I mean? Like, it's the full picture when you have the environment and the patient presentation and the patient noise and the smells. Like, all of those things incorporated into each other make a completely different scenario than plastic. And it's just getting you guys to that point so that you can experience it and start to really put it all together.
So I don't want to like overemphasize temperature, but it seems to me that temperature is like a pretty critical assessment tool for sepsis. I mean, we're not just, relying on that, but that's a tool thermometry is really something we should be using.
Oh, 100%. But like the best
Yeah.
part of that is like you have to do best of, like, you get best of 3 in that appendix, right? They literally, if you went, yeah, he feels hot to me, that's good. So temperature was literally a throwaway criteria in that protocol, because you could have been like, feels hot, feels cold, must be septic, like AMS, and you couldn't figure out why, and he's got a cough, and he kind of felt a little hot, septic protocol. And I think that's also part of like the context you guys aren't necessarily getting, because you also were inundated with COVID where everyone was getting their temperature taken. So we kind of got to, like, that appendix was a lot easier to work your way around, where you walked in going, I treat this patient for sepsis. And they're like, well, okay. Why? He felt really hot. Well, he doesn't feel hot now. And you take the temperature, and the guy's like, his core temperature's like 95. You're like, I meant cold. He totally felt cold. Like, you're doing the right thing for the patient. It's just the way it's phrased, I guess.
So back to the scenario challenge with a heart rate, he's in sinus tach of 150.
Mm-hmm.
All right. We would expect then, that's a compensatory mechanism for the blood pressure falling.
Mm-hmm.
That's exactly where we need to go. We need to correct the blood pressure. We're calling in for the norepi or the dopamine. We get that going in the drip, and that should correct our problem. We should see the heart rate come down.
I mean, that patient with blood pressure at 112, I wouldn't even go for a pressor. I would give them.
So we observed the oxygen was helping, obviously, bring it down a little bit. We could, keep an eye out for the blood, monitor the blood pressure every 5 minutes. It starts to drop, then we know we need to else.
On the best, and honestly, one of the best and simplest things that you can do for any septic patient is fluids. Okay? So the problem in sepsis is that the infection has spread to the entire body, and it's pretty much punched holes in the vasculature. So imagine like a garden hose, right? Garden hose works really well. You want to water your backyard? Cool. You turn the water on, the water goes. Now imagine you have gone and you have taken a barbecue fork and just stabbed holes all the way down your garden hose and turned it to one of those soaker hoses, right? If you want water pressure to go water your backyard, that's not the hose you use. Sepsis is the barbecue fork. Okay, so it goes and it pokes holes in the vasculature of your garden hose, which is your arteries and your veins and your capillaries. So now all that water, all that pressure that you're expecting to get at the other end is seeping out, and it's leaking to the interstitial spaces, and it's called third spacing. So as the plasma kind of leaches out, you get thicker blood, less pressure, and the patient starts to deteriorate. In terms of that's why you start to see in sepsis that blood pressure start to fall. So as they start to lose their mental status, they can't drink enough fluids to kind of keep up. So once you start hydrating that patient, I can't tell you how many times I've given a patient who's like borderline sepsis, like 100 cc's of fluid, and they're like, hey, I feel great. And you're like, you have to go to the hospital still. And they're like, but I don't want to. And you're like, no, you have to go. Sorry, we're like already moving.
So in this patient, this scenario that we just did, though, that's exactly the case you're talking about, where we could give them fluid, but it would be a little bit of fluid. But you're saying that that's going to help, even though they have the septic issue going and they're vasodilating, in the way that you're saying, that little bit of fluid, because they're not completely vasodilating, that fluid added to the circulatory system will actually, in fact, help our situation, as long as it's not an overload.
Yes, and that's the thing, is now you have this complex patient, right, who's got like the junk in the lungs, and they've got the pedal edema. You want to, this is one of those patients, you have a 25-year-old who's in fantastic health who happens to be septic from pneumonia. 2 wide bore IVs, wide open, maybe even a pressure bag. Like, I might even take the blood pressure cuff and onto that guy, right? Their heart's going to be able to take it. 73-year-old who's got like some other comorbidities and got some pedal edema, I would maybe even put a micro drip in that liter bag. Pro tip. So if you have a patient who you're like, I'm not really sure, like they need fluid replacement, but I don't want to like put you can put a micro drip in a liter bag, because this is one of the biggest problems when it comes to like ALS interventions and putting patients on a fluid drip, is that it kind of runs away from you. So if you put it on and it's just going bloop, 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 right? Like 300 drops a minute, you're going to put that, especially if you had a large bore IV, that liter bag is going to be in that patient's body in like 5 minutes flat. So if you don't want to overload your patient full of fluid, put a micro drip set on that, put it about halfway, and you'll give them an adequate volume without overloading them. It kind of keeps it from getting too crazy.
So I want to say from my perspective, because I've heard Scott a couple times during these scenario challenges go fluid bullets. Why would you do that? But with you, I get this, sense that you really kind of have worked this whole fluid replacement thing pretty well and have a great sense of when it's appropriate. So from my perspective, I'd like to hear more in these scenarios, giving us some guidance and some, pushing us in that direction of challenging us to figure out when these fluid situations are appropriate.
Oh yeah, absolutely. We can definitely do that.
Because I'm struggling with it a little bit. I mean, I'm not like in this situation, okay, why would I give this woman this person who's got lungs full of fluid? And you just explained it to me that it's like one of those counterintuitive things.
So it's also a little bit of looking at the big picture, because I feel like looking at like the way Scott is looking at it, it's very, what can I do right now? But pre-hospital care is evolving a little bit from that. Like we do steroids, right? We give steroids. It doesn't do anything to that patient right now. We give Lasix. It doesn't do anything to that patient right now. But when they're sitting in the ER for 3 hours with their asthma attack, and now the mucus influx is happening, that Solumedrol that we gave in the truck is going to go, no, 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 no. And they're going to keep them from getting really bad. Or that Lasix that we gave an hour ago is going to be like, excuse you have to pee. And the like fluid volume is going to start coming down to more normal levels. If you look at the literature and you look at the way that, in terms of like, especially sepsis, fluid is not a bad thing. Fluid has been proven to be one of the saving graces in sepsis treatment, especially since we do not do antibiotics. And looking at it from a longer term, that patient will have a better prognosis if you start pumping them with fluid sooner. And if you look at the grand scheme, in a lot of places, they're actually putting broad spectrum antibiotics onto the ambulances. It's just not in New York, or not in this part of New York. There's parts of the country that have point of care ultrasound. Again, not in New York, because it doesn't matter if you find free fluid in the patient's abdomen. That's probably blood from a trauma. No, because you're still going to a trauma center one way or the other. That trauma center is still 15 minutes away or 10 minutes away. As opposed to like if you're in the middle of Kansas and you find free fluid in a trauma patient's abdomen, you're calling for a helicopter because it's 3 hours by road to the nearest trauma center. It needs to be, as much as the national curriculum is great, it also needs to have some level of specificity to it. So looking at long-term prognosis and looking at the new medical literature that's kind of like available now, there's no reason that we should be so cautious about fluid, especially now that we have CPAP on every single ambulance. You can fix a fluid problem.
So very quickly, what would be the 3 or 4 hallmark signs of sepsis in any age group or demographic? I mean, I think I get temperature is one.
Yeah, but see, it's tricky. Sepsis is tricky.
Yeah.
Because even as much as you're like, it's good, they're going to have a temperature, especially as they get older, because there's no hallmark anymore. As they get older, you have patients who have cold sepsis.
Okay.
And I want to say cold sepsis is more deadly than hot sepsis. So hot sepsis, the body's like, oh shit, that's not good. That's a lot of bacteria. Let's bake it. And the body's like, yep, nope, that's a good plan. Let's do it. Let's bake it. And there's enough metabolic reserves in the body to be like, easy bake oven time. As opposed to like as you start getting older and you start losing those compensatory mechanisms and that metabolic reserve and those glycogen stores, right? The body's just like, yeah, no, we can't. I left that iridescent light bulb at home. We're going to try cold. We're going to go with cold. We just need to be uninhabitable, right? So now you have this older patient who's just, or a diabetic patient, for example, who doesn't have those glycogen stores, who's going to go on the colder side. So you'll see a wide range of things. I want to say the patients I've seen the most, I've seen a lot of UTIs go to pneumonia, go to sepsis. So you'll have a patient who's like, yeah, I have like malodorous urine and I've had this cough, but I'm not bringing anything up with the cough. I just feel a little short of breath and I don't feel good. And you're like, okay. And then you go take a blood pressure and they're like borderline. You're like 100/50. And you're like, do you happen to work out a lot? And they're like, no. And they're like, yeah, I think so. Giving that patient fluid, not a bad thing. I've seen patients who are completely AMS, like full blown, and you're like, oh shit, okay, right? And maybe they're like tachypnic. Usually it's tachypnea. I want to say tachypnea is probably the #1 hallmark of sepsis, but it also happens to be a #1 hallmark of an asthma attack or an anaphylactic attack. So it's hard for you to, it's really piecing all of the parts of the puzzle together. Because if I go to you, hey, here's a patient who is breathing at, 30 times a minute irregularly. They're warm to the touch and their altered mental status. I would be like, okay, sepsis, MDMA, maybe like an upper overdose, okay, or maybe they have a brainstem injury.
Okay, but we could say tachypnic because they're hypoxic, right? I mean, that would be the AMS clue. Tachypnic because they're trying to get more oxygen.
Yes, to meet metabolic demands, but it's
Okay.
also because as the toxins from the bacteria make the patient have an acid-base imbalance. So they're trying to blow off the extra acids produced by the bacterial toxins.
Combination then.
Mm-hmm.
And so the AMS comes in from the acidosis or from the hypoxia?
Yes.
Both.
All of the above. And from hypotension and from metabolic exhaustion and
so it's a cascade of things then.
Oh, absolutely. Huge cascade.
Okay.
Huge cascade. Right. Sepsis is probably one of my favorite things to treat. That sounds really silly. Because you really have to be a detective. Like you really have to go and you need to look at the patient. You need to be like, all right, so what happened? And they're usually like, oh, well, they weren't really quite themselves yesterday. It's usually almost always the elderly patients too. I haven't had a pediatric sepsis because most of the time parents are like, did you cough? Why'd you coughing? You feel hot. Here's some Robitussin. We're going to the doctor, right? Older patients are kind of like really chill about getting sick. Like they're like, yeah, I just don't feel good. They're like, okay, well, you want some tea? And they're like, yeah, that sounds good. And they have some tea and they take a nap and they just kind of like just chill. And then the next day they're AMS and you're like, you had tea. Like what happened? Like you went from being okay to being unconscious. And like you're like, all right, well, do they take medication? Right? You're like, okay, maybe it's a medication. They're like, all right, well, they take, metoprolol, simvastatin, and something else. Okay. Nothing that I'm like, okay, that's something that I should be considering, right? Because usually they're a little tachycardic. Most of the time, especially if they're on beta blockers, that tachycardia, they're like 150 range, you're like not going to see. They'll be like 110. And you're like, well, that was like underwhelming. Okay. So, all right. So you got the blood pressure. Blood pressure could be anywhere. It could be on the higher side. It could be on the lower side. But it's like the combination of like inexplicable altered mental status, a decent neuro exam, right? Because your second guess should also be CVA. Right? So you check the pupils. They got good pupillary reaction and they're moaning appropriately. They don't have any obvious facial droop. Their arms are kind of, evenly toned. And you're like, I don't think this is a stroke. All right, cool. So you check a blood sugar. The blood sugar is like 90. And you're like, no, it's not the sugar. All right, well, did they have any difficulty urinating the last couple of days? Yeah, they were going to the bathroom a little bit more than usual. And that's usually when I'm like, ding, 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 right? Then you listen to lung sounds, and you're like, oh, that's not good, right? You got maybe a little junk on one side. Maybe you got like a little like kind of noise going on. It's just interesting as like a investigation to kind of piece the whole thing together, because there's going to be some things that are like really jumping off the page and obvious, and there's going to be some things that are kind of more subtle.
So with regard to lung sounds then and fluid in the lungs, I mean, if somebody's septic, would that be something that would be absent? I mean, would we, is that something we can look for and rely upon as, fluid in the lungs? No, same thing?
No, it's again,
Same,
it's sometimes yes,
okay.
sometimes no. One
Really
thing
history?
with a history maybe. So if a patient has a history of CHF or a history of pneumonia, it's a good possibility that they just have that like kind of junk living there as it is, and that's
Right.
where the bacteria started to grow. Because remember, we
Right.
talk about how bacteria love moist locations. So if they have like a place to chill and just kind of repopulate, then they're happy. Andrew, whoever's behind you is also moving their hands. It's hilarious.
Sorry.
It's okay, I don't care. I was gonna do a little bit more. So if you have a patient, like this is also one of those things, especially you have like a patient who's like a little bit in and out of consciousness, if they have any sort of like mucus or junk in the back of their throats, that sound can be transmitted all the way down. Just like babies.
Right.
Just like babies. So maybe you want to do a little suction, a little yank hour, and then listen to lung sounds again. Because I've sometimes you're like, oh yeah, they sound real junky, and then you're like, oh, they're perfectly clear. Just kidding. Because it just,
I usually tell my patients to cough.
yes, that's so good. Because it's like, especially when they get older, they get that like junk in like the right back of their throat, and just lives there, and you're like,
so I would love to see more of these in the scenarios when you do it, if you can throw in some sepsis, like, so, what it was tonight, a little bit of, okay, you're thinking it's cardiology, but it's really not, it's sepsis.
oh yeah, I've got zebras for you, don't worry.
Yeah, throw us some curves so we can, this is what, for me, I'd like to see the group be going through, the exploration of the protocols, the exploration of conditions, which I think will help. But, we've got enough anatomy and other basic stuff. I mean, this is the kind of stuff I think we need some help with. At least I do anyway.
You know what? And I think this is stuff that you should be doing in lab, but because you haven't done lab quite in the right direction, you're not really quite getting it.
Well, we can talk to Vinny about that. I can mention to Vinny that maybe we, for what we can do in the labs, because I have to look at the syllabus about what's scheduled after we wrap up with you. But I would love to see more of this scenario based. It could be in the setting of, patient assessment with a mannequin or a student, I don't know what, but giving us the scenario and working through it in the lab would be great.
Yeah,
or
absolutely.
Whatever they're going to give us.
Absolutely. We'll definitely do that.
Nicole, I got a thing for the scenario.
Yeah.
So the sepsis guy, he's definitely going to benefit from the fluids. So let's say you treat as best you can, and he just deteriorates, and then you have to just sedate and intubate, right? At that point, can you give fluids since his airway secure?
Yeah, 100%. 100%.
Gotcha.
You're going to have to make sure you're doing, obviously, your positive pressure ventilations, and when you go to the hospital, they can actually put the patient on CPAP through the tube. I would maybe back off on the fluids a little bit, because you will get a little of that frothy sputum coming up, but at the same time, you now have the ability to deep trach suction. So one of the cool parts is if you have a patient with pneumonia and they get really junky, as you start to give them fluids and this is like kind of basic like childcare kind of vibe, like, oh, you're kind of chunky, like feeling chucky, don't drink milk, drink water, right? So you drink water, you kind of thin all that mucus out, right? Anyone who's ever had bad postnasal drip, you're like, yes, I drink a lot of water. You thin that postnasal drip out. Same concept with the mucus in the lungs. You start to thin it out. And if you're ventilating the patient, you're kind of really creating a turbulent airflow in the lungs because it's not the normal way that you breathe. So you can deep trach suction and get that junk out too.
How are we doing CPAP through the tube? That just blew my mind.
The
Can
hospital.
you explain that?
It's to the ventilator, bro.
It's a ventilator setting.
That's off the ventilator? Oh, it's a ventilator setting.
Ventilator
Okay,
setting
got
in the
it.
hospital.
Got it. All right. Fantastic.
Oh, super.
I wanna share a little scenario that I had.
Oh,
It
yes.
was a while back. I forgot who I was working with, but the call we got was for an EDP. We go up and it's like a 20-year-old mom is telling me that he's had some trouble at school. He was a victim of bullying, and ever since then he just stayed at home, homeschooling and all that.
Mhm.
But now just she said, for example, just yesterday he's been very paranoid and feels like somebody's out to get him. So that's what the call was, EDP.
How old
So I
was
was
the kid?
talking to the guy, like he was like 20, like mid-20s,
Okay.
mid-20s. Yeah, so I was talking to the guy, try to calm him down, and I asked the mom, I was like, does he have any medical history? No, he hasn't been diagnosed with any psych, no, nothing really. Hold on. Just my kid wanted me to go upstairs. Hold on.
Hi, little Martinez's.
so I'm talking to the kid and he's answering appropriately, but I noticed that he was breathing very fast. He was very nervous, very anxious.
Mhm.
So PD gets there, PD, doing their whole roughing up thing, and I was like, no, guys, hold on, let me just talk to the guy. So I noticed that he was breathing fast. And I noticed that just kept getting his drink. I was like, listen, let's just sit down, let's talk. Just tell me what's going on. What's going on? Hold on. I gotta drink some water. I gotta drink some water. So he had a glass of water, a big glass of water, and then I noticed a bunch of other drinks next to him, like soda on the floor. And I was like, man, something's wrong. Something's weird. And I asked the mom, has he always been thirsty like this? And I was like, and she's like, no, just yesterday he's been drinking a lot of water. So just for the hell of it, I just wanted to take a BGL.
How high was
And when
it?
I took it, it read high.
Diabetic.
Not
It read high.
necessarily. Not necessarily. So what other things could it have been other than diabetes? I have two.
Well,
I have two in the top of my head that it could be.
okay,
Pancreatitis.
so
Oh, even three. All
it's
right, pancreatitis. Cool. Thank you. Throwing that one out there.
okay, so not related to diabetes entirely.
Mm-hmm.
So we did just do this in a scenario where the overdose of the calcium channel blocker created hyperglycemia, but no, that's not the case here. I got it.
Actually,
Waving me
four.
off.
I got four. So we got pancreatitis.
Okay.
Joni,
I don't know.
had he been sick recently? Cough, fever, or anything where they would have given him steroids?
As far as I know, the mom was just very concerned because he was just very paranoid.
Okay.
That's all.
Steroids.
Munchausen by proxy.
So steroids.
Well, that's
steroids can actually
great.
cause psychosis, and it can cause an elevated blood sugar. So he could have had steroidal psychosis. Nope, not doing it. He could have had steroids for like a cough or something like that, or an upper respiratory infection that could have caused him to go. Or if he started using it for like anabolics, like if he was weightlifting and like, oh, I'm gonna build up, I'm not gonna get bullied no more, right?
True.
Brain tumor, or a brain or some level of cancer. So either a brain tumor or like an adrenal carcinoma can skew the blood sugars.
So Johnny, what was it?
Did you follow up?
Well, I got no, I didn't. But I know. I got medics. Medics came in, and it was Fidney rescue medics, and they came in and they were pretty much mad at us because they said, what are you guys doing? This is clearly a medical call. Why do you guys have PD here? Why'd you guys made it an EDP? I was like, no, hold on. The call came over as it came over as an EDP, but I checked the sugar and it read high. So then they just, I guess, gave him fluids and went to the hospital after that.
Yeah, or it could have been an infection. That's another thing. The last option on that differential diagnosis could have been an infection. So something like meningitis or encephalopathy. Because remember, we talked about those the bacteria. As the bacteria starts to produce toxins, it can artificially elevate the blood sugar.
What is the mechanism for that? How is that happening?
It depends on which bacteria it is.
Okay, so but it has something to do with the bacterial infection. We can address it another time.
Well,
I'll look it up.
so basically the stress of having an infection causes your body to release corticosteroids,
Okay.
or cortisol essentially. So as the
So
cortisol,
it's
and
the
remember,
steroidal response.
yeah, kind of remember that steroid by Andrew, um, that cortical response. So if you look at like Addison's or Cushing's, right? So as you start to have, or even just metabolic syndrome, right? High levels of cortisol, the body starts to go, oh, stress, we're having stress, must use sugar, right? And it starts to create gluconeogenesis, right? So it starts to take the glycogen, it turns it to glucose, and it starts releasing it into the bloodstream. And then you have altered high blood sugar.
Okay.
Hashtag science.
Yeah.
Joni, that's a really good story. Thank you. I really wish you had followed up, you boob.
I know.
Do that next time.
Seriously.
Follow
Yeah,
up.
I will. I gotta get that MRN
Seriously, you do. Did they take him to Jamaica or they take him somewhere else?
in Jamaica.
Ask Mary.
That was probably like a year and a half ago. I know.
Oh my goodness. Killing me.
I know.
That's a really good like zebra though. You go in expecting it just like EDP, right? He's anxious, he's paranoid, and then now boom, high blood sugar.
But it's like calls like that help me look at things from a wider view now, just because that call's like, wow, this call, I came in thinking it was an EDP, but I saw these little bits and pieces that I noticed he was hyperventilating, he was drinking a lot of water, and I was like, let me just check his sugar. So then prior calls after previous other calls after that, I just, let me give this call the benefit of the doubt. Maybe it's not this, it could be this or that.
Absolutely. It's amazing when when your perspective kind of gets to open up a little bit. And that's part of the problem. It's like, or what I see as part of the problem is you have a lot of medics who are like, another drunk, another drunk. Oh God, like I don't even, and they kind of get that burnt out and they start to get tunnel vision from it, right? So like now they're like, oh, I'm just expecting it to be like another bullshit call or whatever, right? And they're like this, and they don't see those little details that you saw. And like, this goes back to having a lot of power as a pre-hospital care provider. As long as you don't get real salty and you walk into every job like it's the first job, but you're backed by like however many years of experience, you will do right by your patient.
Outstanding. Thank you, Nicole. We kept you long enough tonight.
Indeed. All right, y'all. Any other questions before we wrap it up?
No, thank you ever so. I don't have any. Thank you ever so much again for the extra time.
No problem.
POC 27 appreciates it.
Anytime. I will process this video and post it and send an email out when it's available. And other than that, I will look for some good scenarios that we can all discuss, because I think that was very productive, and we're at that point now where you guys really need to start putting the protocols and everything together.
Agreed. Thank you, Nicole.
You're very welcome. Everyone have a lovely evening.